is live.
Okay. Good evening, everybody. I welcome you back to this scintillating International Pituitary Conclave. We had just very exciting lectures yesterday, particularly related to the pituitary tumors, genetics of adrenal insufficiency and acromegaly. And today, again, we have gathered here for a bunch of exciting topics. And for the first topic, that is related to craniopharyngioma. But before that, I would like to ask Professor Ganpati sir for the welcome address to start the scientific evening today.
Thank you, Ashu Rastagi. Good evening to you all. Greetings from Endocrine Society of India. It gives me great pleasure to be a part of this International Pituitary Conclave, which has been organized by the Department of Endocrinology, PGI Chandigarh, in collaboration with the Endocrine Society of India. This is as a part of our Golden Jubilee celebration. As you know, the Endocrine Society was formed on Jan 10th, 1971. So this is the 50th year of the celebrations. I think we had great lectures yesterday by the doyens in the field of endocrinology, pituitary gland in particular. And it was very well appreciated by all of us. And today's topics are even more interesting. And we also have two case presentations, which are very much interesting. I would like to thank Dr. Pinaki, I think, who single-handedly made this event possible, of course, with the help of Lisa, Saptarishi, and Dr. Sanjay. I'm sure today also you will enjoy with the same zeal, and I think we'll have a lot of discussions today also. And we must make the full use of this International Pituitary Conclave. Thank you, one and all. Jai Hind. Back to the organizers for this session.
Thank you, sir. And to begin the evening, we have the first session on craniopharyngioma management. And I'd like to invite chairpersons for that, Dr. S.S. Zandapani, who is additional professor in Department of Neurosurgery at PGI Chandigarh. Dr. Praveen Salunke, who is additional professor at Department of Neurosurgery, PGI Chandigarh. Dr. Sridhar Chitudi, who is the consultant endocrinologist at Darwin, Australia. And Dr. Karthikeyan, who is assistant professor in Department of Neurosurgery, PGI Chandigarh. So, chairpersons, please.
Thank you, Ashu, and thank you, Ganpati, for the introduction. Welcome, everyone, wherever you are. Good morning, good afternoon, or good evening, and for me, good night. This is 11 p.m. here in Australia, and I hope it will be good morning for Dr. Hermann Muller. It's a great pleasure to have been involved in this meeting. As a spectator so far, I've enjoyed all the lectures. And without taking much time, I'd like to introduce Professor Hermann Muller, who is the professor and head of the Department of Pediatrics in Klinikum Oldenburg, Germany. He's done postdoctoral fellowship at Stanford University Medical Center. He's got a wide spectrum of training from pediatric oncology to hematology to endocrinology and diabetology. I don't know how many years he had spent in training, but he must have spent really long years. And we're really delighted to have him with us and hear him speak on the craniopharyngioma. I'd like to invite the other chairpersons if they have any comments to make. But just as a housekeeping, kindly mute all your speakers while the speaker is speaking, and you will have your turn when you have the chance to interact at the end of the lecture. I'll pass on the mic to Dr. Professor Hermann.
Thank you.
Can you close this slides? Yeah.
Okay. Okay. Can you see? Can you hear? It's okay? Okay. Dear colleagues, first of all, I would like to thank the organizers for inviting me. And I would like to talk on the topic what we have learned about craniopharyngioma management. As you have heard, I'm a pediatrician, so I will talk mainly about childhood onset craniopharyngioma. And this first slide gives you an overview. The craniopharyngioma is a benign tumor located in the skull base, but the close proximity to the neighboring structures such as pituitary, hypothalamic area, and you see here the optic nerve and the carotid arteries. This close proximity makes it clinically, let's say, malignant. It's not a benign tumor when we look at the patients. Because in only very rare cases, a complete resection is possible, as you can see here. This is the rare case with a patient where the tumor is removed completely and you still see the pituitary stalk. In most cases, that's not possible because the tumor has a supracellular extension. And the second reason, which actually makes complete resections rather impossible, is the fact that many pathologists tell us that this tumor has protrusions into the neighboring healthy brain tissue, and these protrusions, they lead to relapses of the tumor. So another mainstay of the therapy is external irradiation. Here you see proton beam therapy, and the main reason is to remove the tumor, but also to assure a good quality of life, which is actually endangered by hypothalamic syndrome. And the main symptom of this hypothalamic syndrome, which is a danger when the tumor has a hypothalamic involvement or the treatment affects the hypothalamus, is severe obesity, as you can see here by BMI STS of the patients. Okay. Okay, when we started many years ago, 20 years ago, our first question was, how frequent is this hypothalamic syndrome and the severe obesity in our patients? And this slide shows you the BMI STS of two cohorts. On the left side, you see the patients who were normal weight at the time point of diagnosis and in yearly intervals. And on the right side of the graph, you see that there is a second cohort, and that's approximately 50% of all patients. They develop severe obesity. And as you can see, we were surprised that especially during the first year after diagnosis, there is a steady and steep increase in BMI STS in these patients who are at risk for obesity. And we were really surprised to see that these patients who were at risk for severe obesity, they were already more obese at the time point of diagnosis, which means before treatment when compared to patients without risk for obesity. So this observation led to the speculation that these patients, that the risk factors and the pathogenic mechanisms leading to obesity are effective already before diagnosis and treatment. So we wanted to know whether we have any symptoms and signs in the records of our patients. So we looked at the records and we looked at the symptoms in the history before diagnosis. And here you see a graph which shows you the frequency. Most frequent symptom was headache, followed by visual impairment, growth retardation, neurological symptoms, weight gain, polyuria and polydipsia as a symptom of diabetes insipidus, and also disturbances of pubertal development. And the numbers in this column shows you the time before diagnosis when these symptoms are noted and found in the records. And as you can see, looking at growth retardation, that's 24 months. That's a pretty long time before diagnosis. And also for weight gain, these symptoms occur pretty early. So these records are a little bit biased because not everything is noted in the records. So we asked the questions, do we have reliable data on weight and growth development before diagnosis of craniopharyngioma? And indeed, in Germany, we have these data because we have a national health survey. And in this survey, all kids born are measured at the time point of birth. That's U1, we call it. U2 is during the first week of life, and so on until U9, which is at 5 years of age. And we were able to look at approximately 100 patients at these data of this health survey. And in these 100 patients, later on, a craniopharyngioma was diagnosed. So we were able to look at the growth and BMI in these patients before diagnosis. And this graph shows you the results for the height STS, the growth before and after diagnosis of childhood craniopharyngioma. This is U1, you know that's at birth, the first week and so on. Diagnosis was made at a median age of 8 years, and then this is the yearly intervals after diagnosis. And as you can see, we were surprised to see that beginning with U6, there was a steady, significant decrease in height velocity in these patients. They stopped to grow, and when you remember U6, that at the end of the first year of life, so from this we speculated that growth retardation is a pretty early symptom in the history of these patients who later on develop craniopharyngioma. What about weight before and after diagnosis? This graph shows the BMI STS. Once again, U1 to U9 diagnosis. And here you see that pretty late in history at U9, that's at the age of 5 years, there is an increase in BMI STS, diagnosis at a median age of 8 years. And this you already know from a previous slide. Then 1 year after diagnosis, there is a steep increase. Looking at these data for BMI STS for two subgroups, the subgroup of patients without hypothalamic involvement and the patients with hypothalamic involvement, we could show that the risk for for the development of this severe obesity was especially the case in patients when they had hypothalamic involvement. In patients without hypothalamic involvement, there was a normal weight at the time point of birth during the first years at diagnosis, and they also kept their normal weight later on after diagnosis and treatment. Okay, whenever you want to make statements about what have we learned about our treatment, you have to look at the results of the treatment, and therefore it's very important to have long-term follow-up in patients. And in Germany, we have a registry. In this registry, as you can see, we are recruiting these patients. In Germany, we have approximately 20 to 25 patients per year. So we are doing this for years and years, and up to now we have recruited actually more than 700 patients with this very rare disease. And we looked at the outcome in these patients, and we especially looked at this group of patients. They were all diagnosed before the year 2001. These are 280 patients. And in these 280 patients, we were able to look at survival rates, overall survival and progression-free survival in 261 patients, and in quality of life and psychosocial status in 108 patients. And this graph shows you the 20-year survival rates in these patients, the overall survival on the left side and the progression-free survival. And these curves simply show you, and we were surprised about this, that even after very, very long follow-up time of 20 years, there are frequent events in terms of death and progressions. So these patients are actually never cured for safe. They always have the risk of a relapse or progression. What about the risk for overall survival and progression related to the age at diagnosis? We see the overall survival was not related to the age at diagnosis, but for very young patients of an age below 5 years of age at diagnosis, the PFS was significantly lower when compared to older patients, which means the younger you are at diagnosis, the higher the risk is for later on recurrences and progressions. And this is actually a very important slide, especially on the right side. We looked at progression-free survival, and we looked at two groups, at the group of patients with complete resections. These were the patients who received gross-total resection, and patients who received incomplete resection. And when you look at textbooks over the years and decades, there was always a statement, you have to treat these patients by gross-total resection because this is the best way to prevent relapses. And when we look at this cohorts, there was no significant difference. There was no improvement of recurrence rate with regard to complete resection. What about hypothalamic involvement? And here we could show for the first time that indeed overall survival in these patients, we always say these patients have a good overall survival, but we could show for the first time that patients with hypothalamic involvement, they have a reduced overall survival rate when compared to patients without hypothalamic involvement. What are the reasons of death, the causes of death in these patients? These were 23 patients we could analyze, 28 patients with hypothalamic involvement and 4 patients without hypothalamic involvement. And you can summarize this table in a way that on the first you have to mention that in a quarter of all patients we had no documented data on the causes of death, but we could see that approximately 25% of all patients, they died due to Addisonian crisis, to salt-water imbalances. And I would suggest or presume that many of the other patients in this group also died due to Addisonian crisis. Okay. This was very interesting. The lower part shows you what everybody expected, that many of these, and most, let's say almost 100% of these patients were on hormonal medication. But we also were asking, who is treating you? And then we were surprised to see that only 2/3 of all patients said they were treated by an endocrinologist, and even 10% of these patients said they had no medical attendance at all, which was surprising because I've shown you on the previous slide the reasons for death. Okay. Let's have a look again at these two situations. This is a patient normal weight, patient's tumor confined to the cellar area. This is a patient with severe obesity, hypothalamic syndrome due to the supracellular extension of this tumor. And we were also looking, how is this weight development during long-term follow-up? This you already know, that patients with hypothalamic involvement have this steep increase, especially during the first year after diagnosis. But in this graph, you see also these black boxes, and these are the data for a median follow-up of approximately 17 years, ranging from 12 to 36 years. And we were surprised to see that patients at risk for hypothalamic obesity, they develop severe obesity. You see the median BMI SDS is +5, but this stays in a way stable at a very, very high level. Okay, looking at quality of life and psychosocial status, we were able to analyze 108 patients. These are the instruments: ERTC, quality of life, MFI, which is analyzing fatigue, and also questionnaire and psychosocial status, which we designed, and we were able to look at 108 patients. And the main risk factor we were interested in was hypothalamic involvement. Okay, and this graph shows you the results for the function domains of the RTC. And as you can see, patients with hypothalamic involvement, when compared to patients without hypothalamic involvement, they had a lower self-assessment of physical functioning. That was highly significant. And looking at the symptom scales, we were not surprised to see that these patients had more problems with regard to dyspnea, because these are the more obese patients. But we were surprised, and that's somehow a new finding, that many of these patients are complaining of diarrhea and gastrointestinal symptoms. And looking at the fatigue score, the fatigue domains as measured by MFI 20, we saw that in patients with hypothalamic involvement, physical fatigue and reduced motivation are problems for the patients with hypothalamic involvement. The psychosocial status, once again, compared patients with hypothalamic involvement and patients without hypothalamic involvement. And we saw that the rate of partnerships and marriages was significantly lower in patients with hypothalamic involvement, and the driving licenses the frequency was lower. That's actually explained by the fact that these patients for sure had more visual impairments due to supracellular extension of their tumors. What was a surprise for us is that there was no difference in terms of employment and professional education, which alludes to the fact that most of these patients don't have cognitive deficits. Okay, challenges in treatment. We wanted to know whether outcome and development of severe hypothalamic obesity was related to the initial pre-surgical situation of hypothalamic involvement already at the time of diagnosis before treatment, or whether hypothalamus sparing surgical strategies or hypothalamus damaging surgical strategies could be of the major effect for this sequelae. So we asked the question, what is the effect of surgical hypothalamic lesions on outcome in craniopharyngioma patients with severe pre-surgical hypothalamic involvement? And in order to give you an impression what we mean by hypothalamic involvement, you have to look at this and understand our grading system for hypothalamic involvement. Whenever the tumor does not involve the hypothalamic area, we say that's no involvement, grade 0. If the tumor involves the area in front of the mammillary bodies, which is this area, we say that's an anterior involvement. And if there is a surgical lesion in this area, that's an anterior lesion, grade 1 lesion. And all other lesions and involvements involving the mammillary bodies in the area beyond are graded as posterior or grade 2 hypothalamic involvement or lesions. That sounds rather theoretical, and this slide shows you some clinical individual examples. On the left side, that's the pre-surgical situation, post-surgical situation, and here you see a small tumor confined to the sellar area, grade 0, no hypothalamic involvement, and the tumor is resected. There is no lesion to the hypothalamus, so that's grade 0 hypothalamic damage, no damage. This is anterior involvement of the tumor. You still see the mammillary bodies, that's grade 1 anterior involvement, and a part of this tumor is resected, part of the anterior hypothalamus is surgically damaged, so that's a grade 1 hypothalamic damage. And this is the worst case, grade 2 involvement, the huge tumor involving all the area of the hypothalamus. The mammillary bodies cannot be identified anymore. And that's a complete resection where you have anterior and posterior hypothalamic damage. That's grade 2 pre-surgical involvement and grade 2 post-surgical lesion. And what we were interested in, this shows you the MRIs of patients. They all had severe anterior and posterior pre-surgical involvement. But the treatment was different. In this patient, only a catheter was implanted, no hypothalamic damage, so that's grade 0 damage. In this patient with severe involvement of anterior and posterior hypothalamus, only the anterior hypothalamus was damaged, so that's interior hypothalamic lesion, grade 1. And that's the worst case, you know already, grade 2 involvement, anterior and posterior, completely resected anterior and posterior lesions. And what we had in our study, we saw that we had 109 patients who had anterior and posterior hypothalamic pre-surgical involvement, and these 109 patients received different treatments. 21% of patients received a surgical treatment which led to no hypothalamic lesion. 27% of patients, in them there was a result of an anterior hypothalamic lesion, and in 52% of patients, anterior and posterior hypothalamus was damaged. So we compared these three groups with regard to overall survival rate, PFS to BMI, SDS, quality of life, and also functional capacity. And this table only shows you that these three subcohorts of patients without hypothalamic lesion, anterior surgical lesion, anterior posterior hypothalamic lesion were comparable in terms of gender, age of diagnosis, follow-up, and tumor size. And when we looked at the progression-free survival of these three cohorts, subcohorts, we saw indeed that patients who received anterior plus posterior hypothalamic lesions, that were the patients, the high-risk patients who had a gross total resection, they had a trend towards a better outcome with regard to progression-free survival. However, this was not statistically significant, but we could estimate that there might be a difference. And this is, I think, the most important slide, which compares the BMI SDS at the time point of diagnosis, 1 year after diagnosis, 3 years after diagnosis, and at last visit for the three groups of patients without hypothalamic damage, with anterior hypothalamic lesion and anterior and posterior hypothalamic lesion. And all of these patients had severe hypothalamic involvement before diagnosis or at the time point of diagnosis. And what we saw, and you know, you have seen this before, that in patients with anterior and posterior hypothalamic surgical damage, there was this steep increase in BMI SDS, which you know already. And there was also the situation that the BMI kept stable at a very, very high level. Actually, in all groups, we saw a certain increase during the first year after diagnosis, but in the patients with anterior and posterior lesions, this was most impressive. We were also surprised to see that patients who had only anterior hypothalamic lesions, their weight development was similar to patients without hypothalamic lesions. And this is a busy slide which can be summarized. We looked at parental, that's on the lower two panels, and self-assessment of quality of life at 1 year after diagnosis and 3 years after diagnosis. And we compared patients without hypothalamic lesion, anterior lesion, and anterior and posterior lesion. And it can be summarized that after 1 year, there was no significant difference. This occurred later on after 3 years, and there was a significant difference, or significant differences in many domains of this PET-QOL in a way that patients with anterior and posterior lesions had lower self-assessed quality of life when compared to patients without hypothalamic lesions. Okay, so from this we conclude that posterior hypothalamus-sparing surgical strategy does not result in increased relapse and progression rates, improves quality of survival, and ameliorates the development of severe obesity also in craniopharyngioma patients at high risk for hypothalamic obesity due to primary pre-surgical anterior and posterior hypothalamic involvement. We could also conclude that anterior surgical hypothalamic lesions do lead to similar weight development like patients without hypothalamic lesions, and they seem to be acceptable with regards to risk of hypothalamic obesity. However, we have also seen that neuropsychological sequelae seems to be related to anterior hypothalamic damage. And we looked at oxytocin and measured oxytocin in 34 craniopharyngioma patients and 73 healthy controls. We looked at oxytocin in saliva and urine measured by an enzyme immunoassay, and we wanted to know whether there are associations with gender, irradiation, and the grade of hypothalamic involvement. And this was surprising. This shows you the oxytocin levels in controls, patients without hypothalamic involvement, patients with hypothalamic involvement. That's a situation before breakfast, after standardized breakfast, and this is a change. And we were surprised to see that patients with hypothalamic involvement, they had similar oxytocin levels. Oxytocin, you have to know, is produced in the hypothalamus and secreted via pituitary, but there were no difference, which we found. However, when we looked at the different grades of hypothalamic involvement, indeed we saw that patients with grade 1, and these are the patients with anterior surgical lesions, they had lower oxytocin levels before, especially before breakfast. And what we also saw that the change of oxytocin in the media of these patients was correlated with the grade of obesity with BMI STS. The higher the grade, the BMI and the grade of obesity, the lower the degree of change in oxytocin. So we did a small cohort. We looked at the neuropsychological effects of a single administration of oxytocin in 10 craniopharyngioma patients, and we administered 24 units of oxytocin, single nasal administration. And once again, we measured oxytocin in saliva and urine, this time by a radioimmunoassay, and we looked at neuropsychological parameters. This only shows you that in these 10 patients, they were comparable with our large cohort of the registry. And these are many data, but I would like to focus on only the fact that 4 of these patients, they were patients who had a grade 1 hypothalamic lesions. These were the patients where we have seen in the other trial, they had lower oxytocin measured. And we compared these patients with the others. This is also important. We looked at the urine, and we indeed found that the oxytocin concentration in urine increased. That's important because when you give it nasally and you measure it in saliva, there might be a speculation that what you are measuring is simple contamination, but we saw that it was resorbed and it led to increases in urine concentrations. And this shows you that in the patients we had, the patients with anterior lesions, these are the patients with solid lines, all other patients are dotted lines, and there was a trend. This is no statistical analysis, but only depicts the single cases, that especially in patients with anterior lesions, this administration led to improvement of their neuropsychological findings. So from this, we conclude that craniopharyngioma patients continue to secrete oxytocin, especially when anterior hypothalamic areas are not involved. Oxytocin may have positive effects on emotion perception, and craniopharyngioma patients improved assignment to negative emotions after oxytocin. I have not shown this, but that was observed. So last not least, a few slides about irradiation. I already mentioned that with modern techniques such as proton therapy, we have better ways to treat these patients by irradiation. And we have done a study where we did a randomization. One part of the patients were irradiated when there was an incomplete resection immediately after surgery, and the other part was irradiated when there was a progression of the residual tumor. And what we saw is that in patients who received an immediate irradiation, the rate of progressions was significantly lower, whereas in patients who received the irradiation only in case of progression, in this group, we found the progressions indeed. So from this, we saw that irradiation is effective in preventing progression of these tumors. This is a special situation of complete resection, but in many cases, this is not possible because they have cystic areas, and these cystic areas are difficult to resect, and they are also difficult to irradiate because these cysts are changing their extension and thereby making it very difficult to do radiation planning. So in many of these patients, we insert an intracystic catheter, and with this catheter, we have the possibility to relieve pressure in these cysts and also to install sclerosing agents. And whenever you do this, you have first to check that this system is tight, there is no leakage. And you see this is done by computer tomography. That's the inserted catheter, and then you are installing contrast medium, and you're looking that this contrast medium stays in the cyst. And this is the protocol published by Ute Bartels, and you see interferon alpha is currently the favored substance which is installed in these cystic structures. We do it 3 times per week for week 1 to 4, so overall 3 million units. And the Toronto experience of Ute Bartels is very promising. They treated a small cohort, and they saw that many of these patients had at least partial remission. And actually, it was very well tolerated. And just recently, there was an international survey which could support these data. And last not least, always an important question, how is the influence and the effect of growth hormone substitution, especially when you know that during the first 3 years, there are frequent events in terms of progression and relapses. And we did an analysis of these treatment variables on the progression-free survival in 170 patients, including growth hormone therapy. And we were actually relieved to see that growth hormone therapy, growth hormone substitution actually had no significant effect on the progression rates in this Cox regression multivariable analysis. So from this, I'd like to conclude my talk and want to say that decreased growth rate is actually a pretty early symptom which should be mentioned. The most frequent combination of symptoms is growth retardation, headache, and vision impairment. The treatment should always be in a way that it is hypothalamus sparing, not doing further damage to the hypothalamic structures, because the prognosis is severely impaired due to neuroendocrine sequelae, especially hypothalamic obesity. Further research is necessary on targeted therapy. There, in this case, the adult type of craniopharyngioma, the experiences are far more developed. There we have already treatment options. They are still under investigation for the childhood type of craniopharyngioma. And also new methods and approaches for treatment of hypothalamic obesity are warranted. And I think what's most important that especially that the multidisciplinary approach in treating these patients is necessary. So I'd like to thank you for the attention. I'd also like to thank the patients who support our research and who are the persons who we are really, who are our friends in doing our research. Thank you very much.
Thank you very much, Dr. Mueller. Thanks for the excellent talk and sharing the long-term studies from your own data of nearly 600 patients. That must be the biggest group studied. I'd like to invite the other co-chairpersons if they're around, or I can start asking the questions from the chat room.
Can I ask? Hello. Yeah, I'm Dr. Dandapani. I'm a neurosurgeon in PGH and DET. And it was a really kind of excellent and very kind of eye-opening talk by Professor Muller. And we have been kind of looking into the studies by Muller. And he has contributed immensely to the understanding of hypothalamic involvement in patients with craniopharyngioma. One question which has always been there in my mind is that most of the neuroanatomical studies have attributed the obesity to lesions in the ventromedial nucleus of hypothalamus. But like most of the studies by Professor Muller, they ascribe the hypothalamic obesity to the posterior hypothalamus or area around the mammillary body. So can you please tell which is the nucleus which you hypothesize to be involved, if not ventromedial nucleus? Because ventromedial nucleus is the one which is known to cause obesity. So can you please clarify this?
Yes, thank you for this question. I'm not a physiologist, I'm not an anatomic person, but I'm just a clinician. And from a clinician point of view, I think that we have learned that there are many nuclei in this area which are described, but we have to think in networks of these nuclei and the regulation. Whenever there is a lesion, it's difficult. We have learned that it's difficult to identify a single lesion and to postulate that the single lesion has this single effect, because we have realized when you have a lesion, this has effects on the neighboring nuclei, on the network. So I'm very, very proud of the fact that we know more and more about this nuclei, but I think there's still many things which have to be learned, and we have to think in network. Which means when we saw that some lesion has effects, we always have to postulate that also other nuclei are affected. So in front of this background, I also see what we found in terms of posterior involvement and lesion.
Yeah, thanks, sir. And one more question, which I think has one person, Dr. Lisa Das, had put in the chat box, which is there in most of our minds. Actually, we do nowadays endonasal endoscopic surgery for craniopharyngiomas. And recently, we had the privilege of operating on the youngest child in the world through nose, a craniopharyngioma. And by God's grace, the child means over 3 months, we could achieve a gross total resection without diabetes insipidus. And so means the question is that means we believe that in endonasal endoscopy, we are able to see the anatomy better and preserve the hypothalamus. Do you have any kind of literature to either kind of concur or differ in relation to transcranial surgery and endonasal endoscopic surgery for these lesions?
Actually, we also have the experience that our neurosurgeons who operate via this approach, endonasal and endoscopic, they have better chances to spare critical structures. So I think this is more and more becoming clear that that's the approach which should be used in many cases in the future. Yeah, you're right.
If time permits, we can take up another couple of questions. There are some questions on the chat box. I'll go according to the order in which they were typed. Dr. Kanhaya Agarwal wanted to know if there are any observations regarding the temperature regulation in patients with hypothalamic involvement due to craniopharyngioma. did you find in your studies or any other studies that you have come across on temperature regulation?
Yeah. Actually, I know it from my clinical experience, but we don't have clinical studies with this question. That would be really interesting, but also a challenge because it's difficult, difficult to get reliable data on these temperature changes and these intolerances. I know that many of these patients, for them, there is no way to do holidays in tropical areas or in areas where there are high temperatures. They have to go to the North Pole or something where it's almost freezing. Then they feel very well. They can only work in places where they have air conditioning because they cannot stand some heat because there's a problem of regulation. But these are actually many personal experiences, but we don't have reliable clinical data of a study on this topic.
One more question from Dr. Muralidharan. He wants to know, how often do you see hypodipsia with diabetes insipidus in the post-operative period and in the long-term follow-up? Is it influenced by the surgical approach?
I have to tell you that I know it from the literature, but there are not many cases I personally treat where I see they have a really disturbed way of thirst or have no thrive to thirst. I know from the rare cases that's a huge problem to treat these patients when they don't have this feeling of thirst, because that's a very, very, very useful reflective way to cope with this very difficult situation. And whenever we have not this, and you have to measure electrolytes or input-output, it's really, it's a pain in the neck to treat these patients. It's difficult during daily life.
Especially the challenge of managing someone with diabetes insipidus, where you're giving DDAVP and then he cannot also have thirst. I've got only one patient and it's a challenge. The water has to be given, measured so much per day, and measuring the electrolytes every so often on telephone. The patient's mom calls us up saying, this is the sodium now, what do you want to do?
It's also a question of age, when you have a small child, it's difficult, really difficult.
I have a question from Dr. Pathak. How does different methods of surgical excision affect overall outcome?
Which outcome?
If I'm allowed, can I clarify the question, please? First of all, danke schön, Professor Müller. That was excellent. Ich bin Neurochirurg, so I'm asking a question as a neurosurgeon. I had been going through the cranial route and the nasal route. What I've realized is that there are a group of patients where the invasion is very much obvious. Invasion into the hypothalamus very much obvious when you're trying to sort of detach the tumor from the surrounding structures. And in those cases, I would, as you rightly showed, we can leave behind a little slither of tissue attached to the hypothalamus rather than trying to be very much aggressive about it. And this reminds me of Professor Harold Hoffman in Canada, who was very much protagonist of trying to peel out the tumor with force. And that doesn't work, I believe. The other thing which I want to mention is that we have a group of patients in India, at least, where they have got cognitive decline also, especially memory function is quite affected in quite a few patients. And I've got one patient who is fine. I've removed it completely, but her memory function was there pre-op and still persists. And that's a difficult problem for the family. So what is the response to that?
We also have the experience that the memory function is a very, very frequent and severe problem in these patients. They are intelligent, but they have problems to memorize, especially on short term. And so what we are doing right now, what we are trying, and we don't know whether it works. They are really suffering from this because there is no daily life. It's very difficult when you don't know what happened 30 minutes ago. So, and we want to try interventions to train memory. We don't know, maybe it has an effect, a positive effect on the memory function. We want to analyze this. So this is a study which is right now ongoing, and we still don't know whether it works or whether it does not work. But actually, when analyze, nobody knows. So we are doing this. And the reason is what you mentioned. It's really a huge problem, and there is no medication which helps, because they are very well substituted endocrinologically, and they still have their memory functions. Vielen Dank.
Professor Muller, in the interest of time, we might have to wrap up. There's one last question from Dr. Muralidharan, which is about obesity management. Have you got any experience in bariatric surgery in patients with hypothalamic obesity in adolescents and young adults?
We started 15 years ago, when then there came patients who said, we are so desperate, we want to do bariatric surgery. And then at this time we said, you have a problem in your brain and not in your stomach, so don't do this. And then there was one lady, she said, I'm so desperate, I will jump from the rooftop and I will kill me. Then we said, okay, and then let's do it. And she did gastric banding and she tolerated it very well. And she said, when she woke up from the surgery, for the first time, she had no hunger sensation. And then we did it in some patients, a small group, and they all had a very positive effect, but years later, they had regained their weight because the procedure was not that effective on a long-term basis. We know that other ways to do bariatric surgery, especially sleeve resection, might be more appropriate and better. And the best way to treat is to do bypass. However, I'm a pediatrician, and as a pediatrician, it's really, I cannot support non-reversible bariatric surgery in a minor, in a kid or so. So when they are older, adolescents, young adults, then we suggest that first you have to do any other thing, but if that does not work, we suggest to do sleeve resection and try it.
Thank you very much, Professor Muller. We will wrap up. We're already 6 minutes over the time. I hand over the baton to the next chairperson and speaker. Thank you.
I thank you. Thank you. Bye-bye.
Thank you, Professor Muller, and thank you, Dr. Sridhar and Dr. Dandapani and other chairpersons for this interesting lecture. I'll just move on to the second lecture in the series, and that is by none other than Professor Amar Ali Agha. And for that, I'd like to invite chairpersons, Professor Sanjay Kumar Badada, who is Head of Department of Endocrinology at PGIMR Chandigarh, Professor Ashish Pathak, who is Consultant Neurologist, Neurosurgeon at Fortis Hospitals, Mohali, and Dr. J.J. Mukherjee, who is Consultant Endocrinologist at Apollo Gleneagles Hospital, Kolkata, India. Sir, please.
Thank you, Dr. Ashu. And I request Professor Pathak to introduce Dr. Amar Agha.
It's a pleasure for me to introduce Professor Amar Agha. And he's going to give a talk on very interesting topics, specifically which concerns the neurosurgeons the most. Professor Amar Agha is a consultant pituitary endocrinologist at BMO Hospital. He's clinical professor of endocrinology at Royal College of Surgeons in Dublin. He's senior editor of BMC Endocrine Disorders. Professor Agha graduated from Trinity College, followed by research and clinical fellowship posts at Queen Elizabeth Hospital in Birmingham and then St. Bartholomew's Hospital in London. His research interests include pituitary dysfunction after head injury and radiotherapy, glucocorticoid replacement therapy, and interaction between growth hormone and thyroid and adrenal axis. He has more than 100 peer-reviewed publications and is the recipient of several national and international research and publication awards. With these few words, may I please request Professor Amar Agha to give his talk. Thank you very much.
Thank you very much. Can you hear me well?
Yes, we can.
Let's share the slides. And I would like to thank the organizers of this meeting for inviting me again. I was at the the meeting of the Society of Endocrinology of India in 2014 in Chandigarh, and I enjoyed my time there very much. So I'm going to talk about post-traumatic hypopituitarism, and we'll concentrate mainly on the anterior pituitary. Can you see the slides?
Not yet. Not yet.
Okay. You go back. Now? Okay.
Yes.
Can you
Yes,
see?
yes.
Okay, good. And can you see it here now?
Yes,
That's
yes,
right.
yes.
Okay, excellent.
Excellent.
And your presentation is going on same hotel which you are stayed here in the Mount View Hotel when you were in 2014 for the Endocrine Congress.
Excellent, excellent. I enjoyed my time in Chandigarh. So traumatic brain injury clearly is a very common disorder. I mean, these are data from Europe and the US. It shows you the incidence. In fact, this is more common than combining breast cancer, multiple sclerosis, and many other conditions that receive a lot of media attention. But the majority of these cases are going to be mild, but about 10 to 15% are moderate to severe. And the commonest cause of particularly significant brain trauma is road traffic accidents, followed by things like assault and other things. But by far, RTA is the commonest cause of this condition. Now, the way I'm going to go about this talk, this is going to be a clinical talk, really. I'm going to talk, present a case history, talk about the frequency of pituitary dysfunction after TBI, the natural history of post-traumatic hypopituitarism, the clinical implications, and some guidelines about screening and management. So this is a patient that we saw some time ago. In fact, he was a man who had a seizure following alcohol intoxication, had severe traumatic brain injury, was in the hospital for 3 months, spent several weeks in intensive care. And it was noted a few days after his admission that he was hyponatremic, and this was attributed to SIADH. He was fluid restricted, but the sodium remained low. And then after several weeks, endocrinology were asked to see this man. And just show you his CT scan. This is his admission CT scan, and you can see blood everywhere here. I don't know if I can use the arrow, but you might be able to see that in the pituitary fossa area, there is some blood as well. And in fact, this was missed. And the patient was treated as your classic head injury, fluid restricted, and he remained very unwell for several weeks. We were asked to see the man. We thought about a different diagnosis here for his hyponatremia, and we checked his cortisol, and this was low, and we proceeded this about 2 months later to do a glucagon test. So the glucagon test, we have a lot of experience with the glucagon test. It's a good test for both growth hormone and cortisol secretion, more for growth hormone. You can see here the cortisol values. His AM cortisol is quite low, and he does not achieve adequate response to glucagon. You would expect a response of over 450 nanomole per liter, which is around 16 microgram per deciliter if you're using mass units. However, his growth hormone response is normal. And we checked other hormones. We checked his ACTH that was low. His testosterone was low normal. You have to remember this man was sick, so that's not unexpected. Lowish LH, but his thyroid function and prolactin were normal. So he was treated with hydrocortisone. His sodium recovered quickly, and this is what you'd expect in cortisol deficiency. The sodium recovers usually within a day or so. And he felt much better. He was discharged to rehabilitation. And then we brought him back for reassessment after, don't know if you can see the top of the screen, but this was after 12 months from his injury. So 10 months after the last test, we repeated the glucagon test, and this time he had a normal cortisol response. So his cortisol secretion, ACTH cortisol secretion has recovered. His growth hormone now is blunted with a peak of 2.2. Testosterone is normal. His IGF-1 is in the normal range. And we decided to do another test to confirm that he continued to have normal cortisol, or he has normal cortisol production. And that's the corticotrophin test. It's a simple test to do. And that was done subsequently and confirmed that this gentleman has recovered his cortisol production. It's a completely normal response, a response of over 50, we take it as normal. But now with the arginine test, which is another test for growth hormone secretion, we couldn't do the ITT clearly because this gentleman had seizures. So the alternative was the glucagon and the arginine, and this arginine now showed undetectable cortisol despite stimulation, and his IGF-1 has dropped. So this case really illustrates very nicely the natural history of this condition. He had acute post-traumatic ACTH deficiency and partial gonadotrophin deficiency. And at 12 months, there was a recovery of his ACTH cortisol secretions, and also his testosterone recovered, but he developed late onset growth hormone deficiency. So what do we know about the frequency of pituitary dysfunction after TBI? So a few years ago, we did this study. This is a study in survivors of TBI. So they were at least 6 months following head trauma. All of them had severe or moderate TBI as judged by the Glasgow Coma scale scores. And those patients had really 2 stimulation tests. So they had a screening test, and if they failed the screening test, they had a second test to confirm the abnormalities. And based on these two diagnostic tests, we had 9% of those have severe growth hormone deficiency. This is an indication for a treatment. 13% had ACTH deficiency, 12% gonadotrophin deficiency, and 12% had high prolactin. Only 1 out of 100, this was 102 patients, only 1 had TSH deficiency. And in this study, we found no correlation between the pituitary dysfunction and the severity of TBI, in other words, the Glasgow Coma scale score. But you have to remember that all these patients had significant head trauma, and the reliability of the Glasgow Coma scale score it clearly is limited in a situation where it's done by somebody else, and by the time the patient arrives at the hospital, often they are already intubated and ventilated. And since the original studies in the early parts of the century, there have been many studies, and I'm just showing of these studies. This is not by no means every study. There has been more, but it's just a representative sample. And you can see in this representative sample, if you go to the end row here, over 1,000 patients, 9% growth hormone deficiency, about between 6 and 10% deficiency in the other axis, and overall about a quarter of them had hypopituitarism. And in fact, the majority of those with hypopituitarism had single hormone deficiencies, although a small percentage had multiple pituitary hormone deficiencies. And this is a meta-analysis that we did some time ago, and this showed you the frequency of TBI in a meta-analysis. Approximately in this study, about 30% of patients, about 29% had hypopituitarism. The commonest deficiency was growth hormone and gonadotrophin deficiencies. So in fact, there have been so many studies in this area that the evidence now is very clear that these patients, particularly with severe or moderate TBI, are at an increased risk of hypopituitarism. So how early can you detect hypopituitarism in those patients, and what happens over time? So we studied 50 patients in the early stage after TBI. Again, all these patients had severe or moderate TBI. So we studied them approximately day 8. This study on a medium of 8 days after their admission to the hospital. And in fact, we did a glucagon stimulation test on those patients after getting a consent from their next of kin, and to assess growth hormone and ACTH reserves. And we detected about 18% blunted response to blunted growth hormone response to glucagon. 16% of those patients had blunted cortisol response to glucagon, and some of those, in fact, had very low morning cortisol. Their some of these patients had a morning cortisol of less than 100, so they were very clearly very severely cortisol deficient, 100 nanomole per liter, that is. As you might expect, they were very sick, so 80% of them have in fact low testosterone or estradiol level. The majority were clearly men. Only one had TSH deficiency or low free T4 with the low TSH, and half of them had high prolactin. And I'm not going to talk too much about the posterior pituitary because this is for another talk, but 40% had some melatonin, salt, and water balance between DI or SIDH. So what happened to them over time? Sorry, I don't have an arrow. So this is the growth hormone response to glucagon. So in the green lines are the patient who had blunted response early on in the acute phase. And as you can see, at 6 months and 12, we studied them at 6 months and 12 months, many of them have recovered, leaving only 3 patients, 3 out of 9, with persistent severe growth hormone deficiency. If you look at the red line, there were 2 patients with the red dots who had a normal growth hormone response in the acute phase, who later on became deficient. And a similar pattern was observed with cortisol. This cortisol response to glucagon. The green lines are the early deficiencies or the early blunted response, and you can see 8 of them had blunted response at 8 out of 50, so that's 16%. And over time, some of them have recovered, leaving 4 with persistent deficiency. But there were 5 patients, in fact, as you can see, this is the red lines, 5 patients who had a normal cortisol response to glucagon early on, who later on became deficient. So we've noticed that nobody really developed new abnormalities after 6 months. So there are some people who develop new abnormalities between 0 and 6 months. This is the time we studied them, but there was nobody who had any new abnormalities detected after 6 months, although some of the abnormalities continue to recover beyond 6 months, although the majority recovered by 6 months. If you look at the other endocrine abnormalities, the gonadotrophin deficiencies, which were mainly testosterone really, because the majority of these were men, young men with a road traffic accident, as you would expect. And the majority of the testosterone has recovered by 12 months, leaving us a couple of, only a few patients, 3 or 4 patients with or 6 patients really with some deficiency. TSH deficiency was very uncommon, only 1 patient out of 50. And the prolactin, it also recovered by 12 months. The prolactin clearly is a stress response. You'd expect it that the majority of the cases, the prolactin will recover. But still, there was some persistent deficiencies even after 12 months. Now, what about the risk factors for hypopituitarism? Individual studies really did not, most of them did not show an association between the Glasgow Coma Scale scores and the risk of hypopituitarism, but the majority of the patients studied had significant head trauma. However, in the JAMA paper that I showed you before, we found that people with more severe TBI had a higher rate compared to people with moderate or mild TBI. Although the data on mild TBI really has to be interpreted with a lot of caution, because most of these the numbers were small and the patients really did not have a sort of a robust confirmation of the abnormalities. So the data on severe or moderate TBI is more reliable. In studies that looked at tried to correlate hypopituitarism with CT scan appearance, they found that diffuse axonal injury, basal skull fracture, and increased ICP, that's intracranial pressure, have been reported to be associated with an increased risk of TBI. And in the group from Turkey, Fahrettin Kilistimar group showed that there is a possible association with autoimmunity, that those patients with hypopituitarism had a higher titer of anti-pituitary antibodies. So there may be an autoimmune dimension to this. So just to summarize the talk so far, I think there is a persuasive evidence that pituitary dysfunction is common in survivors of TBI, particularly those with severe or moderate TBI, with maybe 25% of patients have some degree of hypopituitarism. Anterior hypopituitarism is probably associated with more severe head trauma, particularly if you look at CT appearance, CT scan appearance, and that pituitary dysfunction occurs early after TBI. It is transient in some cases and recovers subsequently. Conversely, late abnormalities may become detectable in the post-acute phase. Although in our data, we did not really show any new abnormalities after 6 months. Having said that, the Turkish group have shown some abnormalities that sometimes developed after 6 months or after a year, although these results are difficult to interpret in a context of dynamic tests, which has limited or has other than perfect reproducibility. Of course, the question here to me as a clinician here is that this is not just about numbers. So does post-traumatic hypopituitarism have a significant impact on the morbidity, the mortality, and the recovery of patients after TBI? Because that's really the key question here. Is this associated with harm, or are we just reporting numbers here? And in our group, this is the study by Mark Hannon in our unit, and he looked at this is a separate cohort of patients, 100 patients who were studied subsequently with severe or moderate TBI. They were predominantly ICU patients, and he measured their cortisol for 10 days, from day 0 to 1 to day 10. And he looked at the cortisol values, and he divided those cortisol values into 2 groups. One is the patient who have a lowish cortisol. In other words, below the first quartile of range, which was 276 nanomole per liter in this study, and the patient who had their cortisol values between the second, the third, or the fourth quartile. So the one with the lowest cortisol versus the one with the higher cortisol levels. And if you look at the left-hand side of this, so it was 8 out of 21, 8 plus 13 is 21, so 8 out of 21 with lowish cortisol died, compared to 9 out of 61 who had higher or healthier cortisol values. So there was clearly those patients with a low cortisol or lowish no cortisol had a higher mortality. Now, he controlled in this situation for the severity of the trauma, he controlled for medications and other factors, and despite that, the signal was there. Low cortisol is associated with higher mortality in those patients. There are other studies that looked at the need for inotrope support in those patients, blood pressure measurement, and other factors, and they found that those with low cortisol had lower blood pressure, required more inotrope support. So there is, I think, significant, there is a convincing evidence that those patients, some of them do develop low cortisol, and that may be associated with worse outcome. What about quality of life? This is a study from Denmark, from Marianne Klosa and her colleagues, and they look at those patients. Those are the patients who had chronic growth hormone deficiency. They were not acute patients. They were studied many months after the head trauma, and they had severe growth hormone deficiency. And she looked at their quality of life using the Nottingham Healthy Profile. So this looks at different domains, and the higher the score, the worse your quality of life. So the black bars are the ones who had head trauma and hypopituitarism. The gray bars are the ones who had head trauma with a similar severity but normal pituitary function. And you can see in all these domains, if you have hypopituitarism after head trauma, your quality of life is worse. And clearly, both groups, whether you have normal pituitary function or hypopituitarism, your quality of life is worse than the background population. But this study has shown clearly that quality of life is diminished if you develop hypopituitarism post-head trauma, untreated hypopituitarism, that is. This is a study from Texas in the US, looking at oxygen consumption after treadmill test. So this is a marker of exercise capacity, measuring the VO2 max here. and patient with GHS is growth hormone sufficiency, those with normal growth hormone response compared with growth hormone insufficiency, i.e. partial growth hormone deficiency, or growth hormone deficiency, i.e. a more severe growth hormone deficiency. To those ones, growth hormone deficiency or insufficiency had reduced exercise tolerance, exercise capacity compared to those with a normal growth hormone response. Another indicator that those patients are paying a price for having hypopituitarism. And the question that follows from this is, does hormone replacement, now clearly, testosterone deficiency, cortisol deficiency, all of this has to be replaced. You can't do randomized studies on these because they have proven benefit. But in terms of growth hormone replacement, does growth hormone replacement in those patients who have growth hormone deficiency, does it improve recovery, rehabilitation, and quality of life? There hasn't been any randomized controlled studies, so we don't have the full answer to this. What we have is small studies which are uncontrolled and showing some benefit of growth hormone. We looked with the help of Professor John Monson. Some of you may know him. He was my mentor in Barts a long time ago, and he looked at the KIMS database. So the KIMS is, some of you may know it, is a growth hormone database for genotropin, which is the Pfizer growth hormone. So it has more than 10,000 patients, probably higher, more than this number, and they have data on patients who are replaced with genotropin on a background of growth hormone deficiency. And he looked at patients with non-functioning pituitary tumors and patients with TBI, and look at the response to growth hormone in both groups to see if you can compare it. And in men, to a lower score, a drop in score means improvement in quality of life. So in men, the response to growth hormone is similar between TBI and FPA. And in women, patients with TBI, in fact, show more of an improvement after growth hormone replacement compared to non-functioning pituitary adenomas. So this data support the notion that growth hormone replacement in those patients as is associated with at least a similar benefit, if not more, than you would get in other forms of hypopituitarism. So in the last few minutes, I'm going to talk about screening, who to screen. I think the data is support screening all patients who have moderate or severe TBI. A group from Britain have written a consensus statement, and they advise that patients who spend more than 48 hours in a hospital should be screened. And now clearly the majority, almost everybody with severe or moderate TBI is going to spend more than 48 hours in the hospital really, so it's essentially the same thing. Patient with chronic repetitive injuries. So I didn't show you data on this, but boxers, again, the Turkish group looked at patients with boxer, whether it's kickboxing or other form of boxing, and those are the ones who have repetitive head traumas, and they do develop growth hormone deficiency. So perhaps those ones should be screened, particularly professional boxers. And in those with mild TBI, now there's a lot of mild TBIs, it's going to be impossible to screen these patients, but if they showed signs suggestive of hypopituitarism, they perhaps should be screened, so selectively, rather than universally. So how do we screen? We believe that it's important that those patients who are in the hospital with severe or moderate TBI should have their cortisol measured in the acute phase, day 1 to day 7. We suggest a cutoff of less than 300 nanomole per liter or 11 microgram per deciliter, or if they have cortisol higher than that but show signs of cortisol deficiency such as hypotension, higher requirement for inotropes, or hyponatremia. So if that's the case, we recommend replacement hydrocortisone. If they don't have these features, the cortisol is higher than 300, then we don't recommend glucocorticoid replacement. And the early phase, really, we don't need to check anything else because there's a lot of changes that occurs during the recovery phase. At 3 to 6 months, we recommend to assess the adrenal, the gonadal, and the thyroid axis, and then treat any deficiencies that are detected. And at least in selected patients, perhaps at 1 year time, we should consider the assessment of growth hormone secretion, particularly for those who showed poor recovery of their after head trauma. The reason we're waiting for 1 year after growth hormone deficiency is because, as I showed you, some of the abnormalities early on do recover. And a growth hormone replacement is not a straightforward replacement, really. You don't want to replace somebody that maybe 3 months later will recover. So it may be reasonable to wait for 1 year, at least 6 months, but between 6 months and 1 year before you replace growth hormone. So in conclusion, undiagnosed hypopituitarism may have an important contribution to morbidity and even maybe mortality associated with TBI. And TBI patients are at particular risk of glucocorticoid deficiency, particularly those with severe or moderate TBI in the acute phase. So screening for post-traumatic hypopituitarism, in my view, should be part of the routine multidisciplinary care for those patients. In the acute phase, clearly you should screen for adrenal insufficiency. It sometimes can be difficult interpreting cortisol values, but you have to use the clinical judgment. 3 to 6 months, assessment adrenal gonadal and thyroid axis. Adrenal axis, I use a synactin test or a corticotropin or ACTH test. It's a simple test to do and it's reasonably reliable. And at 1 year, consider growth hormone test, at least in some patients. And the observational data suggests beneficial effect of growth hormone replacement in post-traumatic post-traumatic growth hormone deficiency. So I'll stop there, and I thank you very much for your attention. I'll take any questions or comments.
Thank you, Dr. Thank you, Dr. Aga, for the very lucid presentation. And there is a lot of questions on the chat box. So the first question was that how long to follow up these patients for the various pituitary hormone deficiency. So I think you already mentioned you should follow up to at least 1 year. Or
yeah. So we feel that 1 year is the reason. I mean, if you diagnose deficiency, and you start them on treatment, you need to follow them up. But those who are normal at 6 months, you may consider growth hormone test at 1 year. But beyond 1 year, I think if everything is normal, then there's no need to follow them up anymore. Now, I know that the data from Turkey showed that some of them may develop abnormalities after 1 year, but I have to say I'm not too convinced with this. And clearly, you have to put an end to testing at some point because there's a lot of these patients. So you have to be practical about this.
Thank you. Other question is that have you seen any patient with cerebral salt wasting? What is the chances in the TBI patients, cerebral salt wasting?
I have to say, in the study that we did, it was a retrospective study, we had one patient who had features suggestive of cerebral salt wasting, but it's a pretty rare occurrence. So the majority of those patients with hyponatremia really have SIDH. And so cerebral salt wasting is probably quite rare after TBI. It does occur, but the incidence is much lower than SIDH.
And any possibility?
Can I ask a question, Amar, directly?
Yeah, Dr. Naki, please.
Yeah. Amar, thank you. Nice, wonderful lecture. So I was wondering, actually, you will show that famous picture, actually, photograph by Professor Christopher J. Thompson, which you often used to show to the audience, for our young audience, the penetrating injury to the orbit, directly the knife is reaching to the pituitary gland. So I was waiting for that. I have a small question for you. What is the type of pathology after if you do an autopsy in the hypothalamus? What is the percentage of pathology in pituitary gland? How much percentage combined necrosis versus hemorrhage? Do you have any data on this in autopsy series?
Can you see the slides now?
Yes.
Yeah.
Okay, I'll show you the slide. I have this as the reverse, as slide. Actually, can you see this?
Yes.
Okay, so autopsy results showed that in those who died from TBI, of course, these are the ones with the most severe the most severe of injuries. Can you still see the slide? Can you see the slide?
No, we can't.
Can you?
No.
No.
Okay. Let me see if I can share this.
Yeah, you can share again. You can share the screen.
Okay, just 1 second. Can you see it now?
No.
Not yet.
Okay. Now?
No.
Okay, it doesn't matter. So basically, yeah, in post-mortem studies, they found that the commonest finding is pituitary infarction due to stroke damage. So typically what happens is that you get a shearing injury to the stroke, these long hypophyseal vessels that supply particularly the 70 to 90% of the anterior pituitary are damaged, resulting in not a total, but usually a subtotal pituitary infarction. So that's one abnormality you can see, which is pituitary infarction. Others, some post-mortem studies showed hypothalamic damage. Others showed direct injury to the pituitary, particularly if you have a fracture of the base of the skull. So these are the common findings. So typically it's anterior pituitary infarction, but it's not complete, it's not total, because some of the anterior pituitary is supplied by the short hypophyseal vessels, which are more protected from injury. And this is what explains why the majority of these patients really have a partial rather than complete hypopituitarism.
Sanjay, can I
Yes.
chip in and
Yes,
just,
sir. Yes, sir.
yeah,
Over to Dr. Mukherjee.
a couple of comments, Amar. Very nice talk.
Thank you.
Regarding the case, I mean, see, GH, LH, FSH deficiencies do recover. We know in the acute phase they can have a GH, LH, FSH deficiency. When you check them later, they recover. For ACTH deficiency to recover is very odd. So my question to you is, the patient that you showed, the first patient that you showed, because in many of these patients, we have neurosurgeon as a chairperson, they get huge doses of steroids, you see. So whether the HPA axis suppression was because of steroids, or secondarily whether the patient got etomidate and that's why the cortisol was low, and because the recovery of cortisol deficiency, HPA axis deficiency in the acute phase, which will be later, as you showed in the patient, a little bit odd. So that's my one question. Second question is, see, we have been talking about post-traumatic hypopituitarism for quite a long time. You have been working on it for a long time, but my experience is when I was in Barts, when I was in Singapore, even back in India, when you go to neurosurgical wards, surprisingly, this has not sunk in that pituitary assessment needs to be done. Only when barn door cases like you showed, where there is hyponatremia, hypotension, where you clinically suspect cortisol deficiency, that is when an endocrinologist is called. Otherwise, we endocrinologists don't even get a chance to investigate these patients. So these one was a comment, one was a question, and the third one was, why is DI so uncommon? If you say it's all the shear injury, etc., neurohypophyseal vessels should get affected in severe traumatic brain injury. So why is DI so uncommon in post-traumatic injury?
Okay, so the first question about the use of steroids. So we excluded anybody who had steroids use, or we don't use etomidate at all in our hospital. But there was none of these patients that had steroids. So any medication, steroids, particularly, typically, in fact, our anesthetists and neurosurgeons don't use steroids hardly for management of TBI, at least at the time when we did the studies. So this wasn't because of steroid use. My hypothesis is that you just get revascularization and regeneration of some of these tissues over time. I suppose the pituitary is you get collaterals, and in the same way that other organs can recover function. The question about the neurosurgeon's lack of engagement, I suppose this could be a question for the neurosurgeons, but it's very difficult managing a neurosurgeon. You have to be very cautious managing neurosurgeons, and they tend to, we have good colleagues, but they tend to focus on the neurosurgical issues. I think they're not too interested in the endocrine part of it, and we try as much as possible to work with them. In fact, the majority of our referrals do not come from in the studies we work with neurosurgeons clearly, but the majority of our referrals come from rehabilitation. Sorry?
Not me, carry on.
The majority of our referrals come from rehabilitation physicians, in fact, not from neurosurgeons. Because what happens in our hospital, the patient is seen by, is under the care of neurosurgeons. When they are out of ICU, they are usually go back to their local hospital because we have a national center. So there's hardly follow-up of those patients by neurosurgeon afterwards. They're just too busy to be following up every single patient with a neurosurgical problem that presents. So it tends to be the rehabilitation physicians that refer these patients to us, and we try as much as possible to work with them. Sometimes it works, sometimes it doesn't. People change all the time. So it's a difficult task. I do accept this. And the third question was? DI,
why don't we see more DI?
Yeah. So in fact, the first study we did, when we looked at when we did the water deprivation test on those patients, in fact, 7% of them had DI, 2% had frank DI, and 5% had partial DI. In other words, they had symptoms, but they were milder symptoms. I suspect my hypothesis is that the way the pituitary is, the vascular supply to the pituitary, the neurohypophysis, the supply tend to come from the short hypophyseal vessels, and then they tend to be less likely to be injured compared to the long hypophyseal vessels that are what we see in the injured and supply the anterior pituitary. But the same thing, like even after pituitary surgery, we know that permanent DI after pituitary surgery is actually not common. We're talking about maybe 5% of cases compared to almost 90% growth hormone, maybe 50% or 40% ACTH deficiency. So it tend to be, suppose the posterior pituitary tend to be more robust in terms of injury, particularly later on. I mean, the acute phase you get it, but not so much in the chronic phase.
Thank you, Dr. Aga. It was a very nice talk and useful presentation. And in view of interest of time, now we are closing this session here. Thank you, Dr. Aga, and the whole audience for active participation. Over to organizers.
Thank you very much, and thank you for the invite. Take care. Bye-bye.
Bye-bye.
Bye.
Thank you, chairpersons, and this Professor Amar Ali Aga. And over to organizers again to just continue the session.
So good evening, everyone. We now move on to the next session, which is a case presentation by Dr. Maharu Malhotra of PGI Chandigarh. To chair this session, may I please invite Professor S.K. Singh of BHU Varanasi, Professor Abdul Hamid Zargar from SKIMS Srinagar, and Professor V. Suresh from SWIMS Tirupati. Sirs, please.
I think this is a very timely case to discuss. In COVID times, when the whole world is frozen by an infective process, that we come to discuss an opportunistic infection and how we create an opportunity out of it. Dr. Banu is a senior resident in the Department of Endocrinology at prestigious PGI Chandigarh and has presented clinical cases at the virtual adult bone and mineral workshops. Over to Dr. Banu. Please go ahead.
Thank you, sir. So good evening, everyone. So I begin with the first case. Is my screen visible?
Yeah, it is.
Yes, so thank you, sir. So I begin with the case, opportunity in an opportunistic infection. So this was a case of a 47-year gentleman who had presented to us with complaints of difficulty in walking and easy fatigability for the past 5 months and weight loss for the past 5 months. So this gentleman had difficulty in getting up from the squatting position and in climbing stairs. It was associated with thinning of legs, but there weren't any sensory disturbances. Also, there were no history of difficulty in the upper limbs. He had marked fatigability. Along with this, he noticed that he had gradually lost around 12 kg weight over this 5 months period. There was not any loss of appetite, any altered bowel habits, or fever. Gradually, he became moribund and subsequently bedbound after an episode of diarrhea, which was managed conservatively at a local hospital. On asking leadingly, the gentleman complained that he had easy bruisability for the past 2 years. He had hypopigmented pruritic lesions on his trunk and limbs for the past 1 year. There was ruddy complexion of the face for the past 1 year. He had low mood and irritability for the past few months. Also, there was history of erectile dysfunction and excessive sleepiness during the daytime. However, there were no history of hyperpigmentation, visual disturbances, polyuria or polydipsia, no history of loss of libido or decreased shaving frequency, no fractures, stone disease, pain abdomen, dyspnea on exertion, or fever. So he was diagnosed with diabetes 3-4 years back in view of oral candidiasis and polyuria, and hence he was initiated on oral hypoglycemic agents. However, due to poor glycemic control, he had to be initiated on insulin, and his glycemic control had always been poor. He was a hypertensive and he was non-compliant on treatment. There was no history of any intake of exogenous steroids or any complementary and Ayurvedic medicines. He was a reformed smoker, and amongst family history, his mother had died at 5 years of age due to some unknown abdominal malignancy. On examination, he had a BP of 140 by 90 mm. He had tachycardia. He had a plethoric round face. He had cuticular atrophy, hypopigmented annular lesions over his lower limb and trunk. There were bruises over his anterior abdominal wall. There were hyperpigmented nails. There was grade 1 acanthosis. However, there were no stria. Also, there was no dorsocervical fat pad or supraclavicular fullness. He had decreased tone and bulk of the muscles. They were flabby, and there was decreased power in both upper limbs and lower limbs. The ankle jerk was absent bilaterally, and there were decreased breath sounds in bilateral intra-axillary areas. Coming to the baseline investigations, he had hypokalemia and an elevated alkaline phosphatase levels. He had respiratory alkalosis and an elevated levels of beta-D-glucan. Coming to the hormonal profile of this gentleman, he had elevated 8m cortisol, which was 3400 nanomoles per liter, and an ACTH of 178 picogram per ml. He had borderline elevated DHEAS levels, which was 509 microgram per deciliter. He had low testosterone, which was 6.25 nanomoles per liter, and also low T4, which was 4.2 microgram per deciliter. And his HbA1c was 10.6%, reflecting poor glycemic control. Coming to the HP axis dynamics, yes, he had an elevated 8 am and 11 pm ACTH in cortisol with a non-suppressible LDDST of 730 nanomoles. However, his HDDST was suppressible. Short of IPSS, we went ahead with IV ADH stimulation in this gentleman, and it was non-conclusive. The ACTH rose by only 8% and cortisol by 22% at the end of the procedure. So we went ahead and did an MRI SELA for him, and it showed a relatively well-defined differentially enhancing lesion 12 into 8 mm involving the posterior half of the pituitary and the stalk. And the impression given was query exophytic adenoma extending along the stalk, query lymphocytic hypophysitis. Subsequently, a CECT abdomen was done, which was suggestive of bilateral enlarged adrenals with heterogeneous enhancement and hypodense areas within. Query adrenalitis, query bilateral adrenal tumors. In view of this homogeneous opacity in the left parahilar region, we went ahead with a CT chest, which was suggestive of fibrobronchiectatic changes in cavitary lesions with areas of breakdown, suggestive of infective etiology, query tuberculosis. So it was very clear from his history and examination and evaluation that this gentleman was suffering from Cushing syndrome. But what was the etiology? So points to favor ectopic Cushing's were that he was a 40-year gentleman. He had a short duration of symptoms. He presented basically with weight loss. There were no stria or hyperpigmentation, gross hyperpigmentation. The cortisol burden was very high. The IV ADH test being non-conclusive, and the radiology confused us more. However, we are considering Cushing's disease as a more common cause of Cushing syndrome and attributing his weight loss to uncontrolled diabetes and the fact that he had a suppressible HDDST and a stalk adenoma. We put our money on Cushing's disease, and our differentials were Cushing's disease with adrenal hyperplasia with query pulmonary tuberculosis, Cushing's disease with disseminated infection involving both the adrenals and the lungs, and lower down was a possibility of ectopic Cushing's lying somewhere with disseminated infection involving pituitary, adrenals, and the lungs. So this gentleman also had an atypical radiology, that was the stalk adenoma. If we consider the normal development of pituitary, we know that it has two parts, adenohypophysis and neurohypophysis. And we know that this adenohypophysis develops from the dorsal invagination of the oropharyngeal epithelium on being stimulated by the neuroepithelium from the diencephalon. And there are normally few cells of adenohypophysis which are lying in the pituitary stalk. So these stalk adenomas, they are not ectopic, but they are derived from neoplastic evolution of these cells normally being found in this stalk. And they can be of two types. One type is the adenoma with extraaxial development, wherein the adenoma arises from the stalk and then grows away from the anterior pituitary. And in this case, the diaphragma sella appears intact. The other scenario is the one where adenoma arises from the stalk and then extends towards the pituitary, and hence it is difficult to make out whether the adenoma arose from the stalk and grew towards the pituitary or it was vice versa. Such adenomas are called as adenomas with intraaxial development. So these stalk adenomas are challenging to the neurosurgeon. Why? Because as illustrated in this picture, we see that in the transphenoidal transtuberculum cellae approach, the diaphragma sella has to be pierced and the adenoma has to be reached. Then subsequently, it has to be dissected from the infundibulum and hence resected. So in doing so, the difficulties encountered are that the tumor edge is not as obvious as it is with the tumors which arise within the anterior lobe. Also, the pile layer at the interface of the pseudocapsule of the tumor and the stalk is quite tough, and hence sharp dissection is required to preserve the anatomical integrity of the stalk. And hence, some surgeons prefer the superior approach, that is craniotomy, while others prefer the transphenoidal transtuberculum cellae approach. So this was a case series of 10 patients, wherein 4 patients had microadenomas with extraaxial, and other 6 patients had adenomas with intraaxial development. And in this case series, they showed that pre-op MRI was correctly able to visualize the tumor location, and it corroborated with the intra-op findings in 6 out of total 10 patients. And all these patients, pituitary stalk was preserved while doing the surgery, and all had remission post adenomectomy and were rendered hypocortisolic. And only one patient in those who had extraaxial development and one in those who had intraaxial developed panhypopit. And amongst the local complications, only one had bitemporal hemianopia. That too because the location was close to the optic chiasma. So this study suggested that these stalk adenomas overall have a good post-surgical outcome. So this was another case from our institute. This was a gentleman who had presented with pain abdomen and was subsequently found to have suffering from acute pancreatitis. He had on evaluation stigmata of Cushing's and an ACTH dependent Cushing's, biochemistry suggestive of ACTH dependent Cushing syndrome. And on MRI, we were able to localize a stalk adenoma. Subsequently, this gentleman was operated upon and he went into remission, and he was subsequently put on hormonal supplementation. So after all, seeing all the trend of this cortisol, without the gentleman being on any medical management for the same, his cortisol levels had gone on to decrease. So was he really heading towards auto-remission? And if yes, what are the possible mechanisms? So we know apoplexy is common in macroadenomas, and however, it has also been reported in patients with microadenomas, which can undergo autoinfarction, hence causing self-remission of the tumor. Also, there can be involvement of the pituitary gland by the infectious process. Similarly, at the level of adrenal gland, there can be glandular infarction because of a blunt microthrombi, because of the prothrombotic state seen in patients with Cushing syndrome. Also, there could be fungal infection of the adrenals, which leads to endovasculitis and subsequently fungal emboli causing caseation necrosis. Also, they can be because of the increased ACTH drive and the hyperplastic glands and subsequently increased blood flow to the adrenals. There can be congestion of the adrenals, and when subsequently endotoxins further they are influenced by the endotoxins, they can be hemorrhage into the gland, which we commonly know as Waterhouse-Friderichsen syndrome. So microadenoma undergoing self-resolution, that too in a stalk, has also been previously reported. This was a case of a 42-year female who had presented with two microadenomas. So and due to non-availability of IPSS in the institute, this lady was being managed with ketoconazole. After 1 year of medical management, when she finally the ketoconazole was stopped, she presented with symptoms of hypocortisolism and headache. And when subsequently MRI was done, it was suggestive of a disappearance of this microadenoma. So self-resolution does occur in microadenomas, that too corticotropinomas. Similarly, this was another case report from our institute, wherein 18-year-old gentleman who had ACTH-dependent Cushing's was awaiting TSS, and during the process, in the meanwhile, he presented with skin lesions and varicella pneumonia, and ultimately he developed shock, and on evaluation, he was found to be hypocortisolic. So when MRI was done, it was suggestive of apoplexy of his adenoma, and hence the patient had auto remission. So far we have this gentleman who has been diagnosed with Cushing syndrome, who was initiated on antibiotics, pneumocystis carinii pneumonia prophylaxis, and anticoagulation. However, we did not start any medical management because we were doing the dynamic testing. So somewhere in the investigations and imaging, we had some suspicion of infection of the lungs and the adrenals, which could be fungal due to rising beta-D-glucan levels. So we initiated him on antifungals empirically. Subsequently, this gentleman underwent bilateral adrenalectomy on 23rd of February so as to debulk the disease and offer him cure. However, post surgery, he had a sudden arrest, but fortunately, he was revived and he was on assisted ventilation for almost 3-4 days, after which he was weaned off. So this was the gross specimen from this gentleman. On to the right is the normal hyperplastic adrenals in a patient who has non-infective adrenal enlargement. And on to the left is the adrenals from this gentleman, which were bulky, weighed around 30 to 40 grams, and showed areas of fat deposition and necrosis. On cut section, on histopathology, it showed multiple nodules, both large and small, and these nodules were concentrated more towards the medulla of the adrenal. And this focus section of one of the nodules showed central necrosis within, with palisading histiocytes onto the periphery. So subsequently, on H&E stain and per iodic acid shift stain, we delineated this multiple variable size spores which had an eosinophilic cell wall, and the impression given was of adrenal histoplasmosis. So this diagnosis of histoplasmosis was not that too surprising, because somewhere in the radiology and the microbiology workup, there was some hint towards infection. So why are infections in Cushing so common? We know that infections are the second most cause of mortality in Cushing's, just after cardiovascular causes, and the prevalence of infections is to the tune of 21 to 53%. So what are the reasons? So reasons are multifactorial. Cushing's is a disease characterized by hyperglycemia, which can lead to neutrophil dysfunction, can cause glycation of the complement components, rendering them ineffective. Then there is skin damage and there's impaired wound healing, and we know that skin forms the first line of defense. Then subsequently, steroids have a far-reaching effects on our immune system. They paralyze both the cell-mediated immunity and the humoral immunity, with the major effect being on the cell-mediated immunity. They shift the balance from CD4 cells to the CD8 cells. They decrease the endothelial adherence of the neutrophils, their extravasation, their degranulation. They hamper the activity of NK cells, and subsequently they predispose the individual to multiple infections, especially the fungal and the viral infections. So why are these infections so sinistral in Cushing's? So the patients with Cushing's, they are not able to mount fever, they don't have pain. So there are masking of signs of inflammation by the cortisol excess. Also, these infections tend to be disseminated and invasive. There are infections with opportunistic organisms, and co-infections can occur. Also, control of hypercortisolic state can lead to unmasking of occult infections due to reconstitution of the immune system. And not the least, there can be further flare up of the hypercortisolic state due to stimulation of the CRH-HP axis by the cytokines in the phase of infection. So this is a paper by Graham and Tucker who showed that with the varying levels of cortisolemia, the organism which is causing the infection also varies. So a cryptococcosis is seen at levels less than 70 microgram per deciliter, whereas levels higher than 121 micrograms, the cutoff which they derived from discriminant analysis, pneumocystis infections are more common. and the patients who have uncontrolled hypercortisolemia ultimately succumb to their infections. Subsequently, Sarlis and colleagues showed that with the increasing degree of cortisolemia, the severity and the fulminance of the infections increases. And amongst cortisol, urinary free cortisol, and 17-hydroxysteroids, the maximum predictive value was for 17-hydroxysteroids in predicting the severity of the infections. So coming to the fungal infections in Cushing's. So we know that invasive fungal infections are common. However, the more common organisms are cryptococcus, Pneumocystis carinii, aspergillosis, and candidemia. Histoplasmosis is also reported, but it is less common. And peculiarity about adrenal histoplasmosis is that it is the local concentration of corticosteroids which is more important rather than the systemic one. And hence the site of lesion is zona reticularis, wherein there is the maximum gradient of cortisol excess. The patients can present as acute infection, or they can be reactivation of chronic infection in areas where the histoplasmosis is endemic. So on searching literature, we could come across only one case of adrenal histoplasmosis reported so far. This gentleman was from Malaysia. He was 45 years, who had ACTH independent Cushing's, and he had a Cushingoid habitus with secondary diabetes, hypertension, and osteoporosis. At that time, maybe MRI was not available, so CT was done, which was normal, and he had a left adrenal nodule, and subsequently underwent TBI and was offered cure. So in a patient with Cushing's, we should always look for signs and symptoms of infection. We should consider opportunistic pathogens in our diagnostic workup. If we have doubt of any respiratory infections, we should get a CT scan done and then treat accordingly. Even when the patient does not have any symptoms of infection, we should do the routine screening test for asymptomatic UTI or bacteriuria, and we should consider adding prophylaxis for pneumocystis if the cortisol levels are high. So final diagnosis in a gentleman we made was Cushing's disease with disseminated histoplasmosis, adrenal plus pulmonary, and we initiated him on oral hydrocortisone, fludrocortisone, thyroxine, and itraconazole. However, post addition of itraconazole, his alkaline phosphatase levels began to rise, and they reached as high as 2000. So our possibilities were maybe if it was drug induced, or since the gentleman had high ALP to begin with, it could be some granulomatous hepatitis. Maybe the fungus is infecting the liver as well. Or since the patient had undergone CPR and there were few rib fractures, it could be bone-derived alkaline phosphatase. So considering that, we changed the antifungal therapy to liposomal amphotericin B. So at follow-up, after having received 20-30 days of amphotericin B, this is how the gentleman looks like. His plethora has disappeared. He has lost weight. He has a tracheostomy which is planned for decannulation soon. He has the homogeneous opacity in the left parahilar area has also disappeared. So our plan is to continue antifungals and decide on the long-term therapy for disseminated infection in this gentleman. He is on hormonal supplement replacement, anticoagulation, and our plan is to rehabilitate him in terms of muscle strength, bone health, and glycemia, which has improved significantly post-surgery, and to monitor ACTH levels and intervene change in the size of the adenoma for Nelson's. So the learning points in this case were that we should always have a high index of suspicion for occult infections in patients with Cushing syndrome. Stalk adenomas, though rare, do occur in clinical practice and they have good post-op outcomes. Bilateral adrenalectomy may be life-saving in certain situations. With this, I thank you all for your patient listening and my department, especially Professor Pinaki sir, for giving me a chance to present here. Thank you.
Excellent collection of cases and analysis. Cushing's and Cushing's disease never stops surprising endocrinologists. And this again emphasizes that we need to keep our eyes open in relatively rare areas like infection in Cushing's. I'm sure that my co-chairperson would like to make a comment or two. Excellent presentation, Banu.
Thank you, sir.
Suresh or Anil would like to make a comment?
Yeah. Can I make a comment?
Yeah,
Good
please.
evening, sir.
So I think Banu, you very nicely presented this case, and it was a very challenging case during this hospital stay. Patient is still in hospital. And we were aware about the entity of the stalk adenoma, as we have seen earlier, 2 patients who had a stalk adenoma. And fortunately, they both got surgery done. And unfortunately, this patient was very critical, and very surprisingly, because adrenals were very big in this patient. So possibly it was looking like that there is something more than that, and it was suspected that there might be some infection in the adrenal as well. So it was adrenal histoplasmosis turned out to be. A very interesting part was that despite of adrenal involvement by the histoplasma, his cortisol levels are too high. It was a 3,000 nanomole per liter. That was another surprising point, despite of bilateral adrenal involvement by the histoplasma. And one thing which we have seen post-operatively, that his ACTH has not peaked after bilateral adrenectomy. So I feel that possibly the pituitary may also be involved by the process of fungal infection. That will be the possibility. Because the delta change in ACTH is hardly, rather it has gone down in fact. It was 148 and now it is 114 picogram per ml. So failure to rise in ACTH, possibly the pituitary may also be involved by the same process.
Anil, I was just wondering, if you look at these adrenals, was this histoplasmosis incidental? Because, normally if you have such an extensive disease, you should have a hypocortisol state, and that might indirectly explain the elevation of ACTH. But when you have an ACTH elevation and you have a genuine hypercortisol state, the focus of the disease is likely to be elsewhere.
The dictum is that the 90% of the adrenal has to be involved before it manifests as adrenal insufficiency. So here certainly that we have a histological documentation of a bilateral adrenal histoplasmosis. There is no doubt about that. But we presume that still the adrenal was functional. I believe that there might be some macrophages or some histiocytes, they might be producing cortisol in response to ACTH. That's a theoretical possibility. But certainly histoplasmosis cannot be, histoplasmosis was definitely there. And adrenal gland was also involved, but still here a hypercortisolemia means the restriction was at least there was some adrenal reserve.
Banu, I would love to know what is this patient's current radiology of the adrenal glands? Once she has been on treatment, the radiology.
Sir, actually, we have not repeated his radiology of for the adrenals, but we are planning to do so. We got an FDG PET done, which showed some uptake in the area of left adrenal. Maybe it was post-inflammatory change, but overall, the adrenals were not visualized in the PET scan.
JJ had a question.
My question was, Dr. Bansali, that Dr. Bhanu, fascinating case. I mean, as the case went on, I kept going round and round. What's happening here? My question is, what the cortisol was gradually coming down. Did I get it correct before
Right,
you
sir.
did adrenalectomy?
Yes, sir.
So my question is, when somebody with Cushing's disease with a stalk adenoma develops concomitant histoplasmosis and cortisols are coming down, which means that there's gradual destruction of the adrenal gland by the ongoing histoplasmosis. So in this case, doing an FNA, getting the diagnosis of histoplasmosis and managing with antifungals would have been an option rather than chopping them out. So my question is, the decision to chop them out when cortisols were already well within the normal range.
JJ, I think you are partly right because the cortisol was going down, but he was treated with ketoconazole for a short time and eventually he received intermediate prior to the surgery. So I think that was the reason for a fall in cortisol in this patient.
Actually, patient was critically sick. Patient was critically sick, and we cannot wait for a long time for this patient. We need a definitive treatment. Other thing is actually in the histopathology that the adrenal hyperplasia was also there. That explains because of this stalk adenoma that was responsible for the hyperplasia. That says because destruction by histoplasmosis was there, but hyperplasia is also there.
So my question, how are you going to follow this adenoma now? Are you going to do recurrent, and is Nelson's described in this kind of a pit adenoma, stalk adenoma?
I think those stalk adenomas who have undergone surgery, the Nelson has not been, Nelson has not been described in these stalk adenomas, in fact, because they have all undergone a pituitary surgery, whatever the literature reports of 10 patients there. So like our patients, we already had 2 patients and both underwent, in fact, stalk surgery. So we didn't have experience in that. But so far available literature did not show any occurrence of a Nelson after bilateral in patients with stalk adenoma.
JJ, probably, now that Banu presented in a very systematic fashion, when they must have been treating the patient, things must not have been that simple. So I'm sure that
I agree. I already congratulate.
Every second day.
I agree. I already congratulated and clapped. The patient is alive with no hair, I saw.
Yeah.
Amazing.
I will also tell you that Bhanu knitted the history very well. And she presented very well. Yes, the course was very turbulent. Course was very turbulent. The diagnosis was not so simple as it has been presented. It was very difficult, very challenging. Bhanu has very nicely knitted.
Suresh or SK Singh has a comment or a last word?
Sir. So one thing odd in the beginning was weight loss in Cushing syndrome. So was it because of the histoplasmosis also? And second thing is hypokalemic alkalosis, which is very rare in pituitary Cushing. So only 5 to 10% have that. Whereas most of the times when we think of weight loss and hypokalemic alkalosis, we often think of fast growing ectopic lesion. So why there was hypokalemic alkalosis, and I mean, is the cortisol so high? And the second thing is the weight loss really due to histoplasmosis in the lung? At that time, probably it was only there in the lung.
Suresh, Suresh, once I saw that lung radiology, I thought it was an ectopic Cushing's, and that pituitary thing was incidentaloma. Telling you honestly, when I was looking at that, I thought that would explain everything. You know, cortisol being on the higher side, ACTH being on the higher side. That was so. Yeah, and then weight loss. It would explain everything. Rest of the things.
I think Jargar, the pituitary incidentaloma, it was a stock incidentaloma, which is very, very rare. I think not been reported. It's a pituitary.
No, I'm just saying, it was always first time, man.
Yeah. I think the weight loss was attributed to histoplasmosis only. He had a systemic, he had a diffuse disease, not only in lungs but in adrenal also. So that was the reason for that. And why he had hypokalemia? Because the cortisol burden was
no. He had a diarrhea and admitted outside hospital for 7-10 days, and this central line was put in for that. So that was the probable reason for hypokalemia and this metabolic abnormalities.
But he had a cortisol burden.
As touch
clinical meeting. Thank you so much.
Sir.
I think in order to save some time, I'm sure that all. Yes, you want to say a word?
I want to say, sir, just one point. Sir, actually,
yeah.
Can I say, sir?
Yeah, please go ahead.
Okay, Bhanu, the rise in alkaline phosphatase also could be because of the granulomatous hypophysitis, which is flare up actually by decreasing glucocorticoid level, because sometimes after glucocorticoid withdrawal we will have some kind of immune reconstitution syndrome, like especially this is found in PCP pneumonia and all those things. Initially we may not have any sign of inflammation, and once the patient is cured, actually you will have all signs of inflammation which will be appearing. Is it so?
Sir, granulomatous hypophysitis, sir. Granulomatous hepatitis, yes, sir, it could be there because the alkaline phosphatase was elevated even in the beginning. So it further rose after itraconazole. So maybe the pathology was there, which got unmasked by the cure of the patient. So maybe we need
I think in order to save time now, I think before we end up in messing next session, I think we close this session and hand it over to the organizers. I know the case is fascinating and queries from the clinicians will continue coming. Over to the organizers.
Thank you.
Stay back for the next interesting case.
Thank you.
Thank you, sir. Thank you, chairpersons. Thank you, Bhanu. I hand it back to the organizer to take the session forward.
Good evening, everyone. So now we move on to our final session. And to chair this session, I would like to invite Professor Nikhil Tandon, Professor and Head of Department of Endocrinology, AIIMS, New Delhi, Professor Ganpati Bantwal, President, ESI, Brigadier Narendra Kotwal, Army Hospital, New Delhi, and Dr. KP Singh, Consultant, Fortis Hospital, Mohali. I would like to request chairpersons to kindly introduce our next speaker. Thank you.
Hello. Oh,
yes.
Sorry, actually, Dr. Narendra Kotwal is not now brigadier. He is now Major General, actually.
Sorry, sir.
I was going to say that it's we need to elevate Dr. Kotwal to his rightful rank. So that's the first rectification. Will you will the local organizing team actually introduce the presenter, and then maybe we will get started after that?
Okay, sir.
And I'll request Dr. Ganapati to take lead in the discussion on this one. I've just actually come from another session. I'm going to take a little while to wind down and then restart. So,
oh, sir, you can do it.
Thank you.
Yeah, I think.
Okay, sir.
Yeah. Dr. Jasmeet Kaur Bala, she is a senior resident Department of Endocrinology at PGI Chandigarh. Did her MBBS from KMC Manipal University. She's won the first prize for physiology, pathology in the university exams. So she'll be speaking on a case of tall stature. Over to Dr. Jasmeet Kaur Bala.
Thank you, chairpersons, and good evening to all of you. So I'll start my screen sharing. So are the slides visible, sir?
Yes, Jasmeet, yes.
So with this, I'll start with a case of tall stature. So starting with the demographic details of my patient. My patient is. Should I continue?
नहीं पीना है उसको, सब निकाल रहा है साइड से.
Should I continue, sir?
दे दो.
Yeah, please continue.
Yeah, can I just request anybody who's not speaking to just ensure that their microphones are muted? At the moment, perhaps only Dr. Jasmeet's microphone can be switched on. Yeah.
Thank you, sir. So my patient, Mr. SK, he's a 42-year-old gentleman. He's unmarried. He belongs to Saharanpur from UP in India. He's educated up to the high school, and he's a farmer by occupation. The age at first presentation was 37 years. So he presented to us with history of arthralgia since the age of 30 years. These are non-inflammatory with bilateral symmetric involvement of the large joints and also with history of low backache. There was associated swelling of both knee joints. By the time he presented, he had developed deformity of the right knee. The other complaint was the history of facial asymmetry, which was also noticed around 30 years of age. This was associated with prominence of the right half of the face. In view of worsening of these complaints, he first sought medical advice at the age of 37 years. So on probing further, we found that he had history of features suggestive of growth hormone excess in the form of excessive height gain, which began about 10 years of age. There was not associated history of precocity. He continued to grow tall till the age of 30 years. There was associated acral enlargement, history of excessive sweating, jaw protrusion, widening of the space between the teeth. There was history of obstructive sleep apnea, chronic constipation. He also had history of recurrent acneiform eruptions on the back and the thighs, which would heal by scarring. So in this scenario of features suggestive of growth hormone excess with likely arthritis and presence of facial asymmetry, we did not get a history of headache, visual deficit, seizures, hypertension, past history of diabetes, neck swelling, renal stone disease, nor was there any history of nevi abnormal pigmentation, hearing abnormality, bony pains, muscle weakness, or fractures. So his personal history was suggestive of history of chronic moderate smoking with a smoking index of 225. He had history of decreased libido, erectile dysfunction. He was a single child and the family history was non-contributory. So coming to the examination, his anthropometry was suggestive of tall stature. His height was 196 centimeters, which is above the 97th percentile, plus 2.7 STS. He was obese as per the Asian criteria of obesity. His vitals were suggestive of a pulse rate of 60 per minute. He was normotensive. The systemic examination, the CNS exam, as a part of CNS examination, his visual acuity was done, which was 6/18 bilateral. Visual fields were normal by confrontation. Fundus was suggestive of bilateral, mild temporal disc pallor, and rest of the systemic examination was non-contributory. The head-to-toe examination again revealed evidence, features suggestive of growth hormone excess in the form of prominent supraorbital ridges. There was also hypertelorism. There was prominence of the right half of the face. There was prognathism, dental malocclusions, increased spacing between the teeth. He had acanthosis nigricans grade 2, no skin tags, however. He had developed scoliosis and right genovalgum. The second picture here shows the evidence of those recurrent scarring acneiform lesions on the back, which he had developed over the last 5 years. So coming to the baseline investigations, which were done in 2016, his complete blood count was suggestive of pancytopenia, on the evaluation of which he was found to have folate deficiency. His biochemical profile was suggestive of increased ALP, and there was evidence of dyslipidemia. The calcium profile was suggestive of low phosphate levels against a vitamin D of 23.6 nanogram per ml with IPTH of 19.3. And there was, so based on this workup, we went ahead and we calculated the TMP-GFR, so which came out to be low in this case. Further on, we did, in view of low TMP-GFR, which was suggestive of renal phosphate wasting, we did an FGF 23. So this was done with a C-terminal assay by ELISA. This also came out to be elevated, 316.9 relative units per ml. So coming to the hormonal profile, his IGF-1 was 896 nanogram per ml, and GHGT was non-suppressible with another GH of 70.8 nanogram per ml. There was evidence of hyperprolactinemia, and he had a cortisol of 165 against an ACTH of 71.65, probably reflective of the GH inhibitory action on 11 beta HSP1. He had normal thyroid functions. There was evidence of secondary hypogonadism, and he was also detected to have diabetes. ECG was suggestive of sinus bradycardia with VPCs, and the 2D echo was suggestive of an ejection fraction of 60% with evidence of concentric left ventricular hypertrophy. This was the baseline ECG. The ultrasonography also revealed evidence of thyromegaly as well as testicular microlithiasis. Coming to the radiology, so in this X-ray of the skull, we can see there is widening of the sella, and the underlying sphenoid bone shows evidence of sclerosis. And the second X-ray is that of bilateral knee joints. So this is suggestive. If we in this second X-ray of the bilateral knee joints, we can see that in both the knees, there's loss of joint space, there's narrowing of the joint space, and this presence of osteophytes. So in this given scenario, this is a late stage of osteoarthropathy in the setting of growth hormone excess. Secondly, there was evidence of bowing of the tibia on the right side, and this right tibia is showing evidence of sclerotic lesions as well as lytic lesions. Similarly, the other bilateral femur and the other tibia is showing areas of lytic lesions. So we had sclerotic as well as lytic lesions. There was evidence of an advanced osteoarthropathy with osteophytes, and there was bowing of the tibia. So moving on to the next image, that is of the CMRI sella. So in this, as pointed by the blue arrow, there was the pituitary was normal. Underneath, there was an evidence of a solid, complex cystic lesion in this involving the sphenoid bone and the sinus. In the T2 image, also we can see the normal pituitary. The third image of the sagittal section also reveals a presence of a ground glassing involvement and a heterogeneous lesion involving the frontal bone with mild indentation of the underlying frontal cortex. In the infracellular region also, we can see there's a heterogeneous lesion. The sella is seen separate from this lesion, and there's presence of a posterior pituitary bright spot. So further on the NCCT head bone reconstruction images, here we can appreciate there's evidence of sclerotic changes involving the greater wing, the body, as well as the lesser wing of the sphenoid. And also, if we compare the right ramus of the mandible to the left side, we can see the right ramus is enlarged with evidence of heterogeneity. So further, an MDP bone scan was done in this patient. So both the anterior images as well as the posterior images are suggestive of increased osteoblastic activity, predominantly on the right side, involving the right frontal bone, right mandible, there was a right sphenoid, right femur, right pubic bone, and part of the right tibia. So this was suggestive of polyostotic fibrous dysplasia. So with this background, our diagnosis was that of McCune-Albright syndrome with polyostotic fibrous dysplasia, acrogigantism, secondary diabetes with acromegalic osteoarthropathy, acromegalic cardiomyopathy as suggested by the presence of left ventricular hypertrophy and cardiac conduction abnormalities in the form of multifocal VPCs. And there was evidence of secondary hypogonadism as well as hypocortisolism in the setting of this, in the absence of a visualized adenoma here this hypogonadism can be attributed to the presence of hyperprolactinemia, and there was evidence of FGF23 mediated hyperphosphatemia. So even in the absence of visualization of an adenoma, in this particular case, we went ahead with total hypophysectomy. So there were financial concerns with regards to the use of medical management. The intraoperative course, during the intraoperative course, the route of the surgery, initially it was microscopic TSS, but later on it had endoscopic TSS had to be resorted to because of the finding of hyperostosis in the sphenoid. And the intraoperative findings revealed the presence of a moderately vascular lesion, which was removed from the sinus cavity, and thereafter the patient was subject to total hypophysectomy. Post-operatively, the patient had transient DI followed by SIADH. The growth hormone levels in the post-operative period have been consistently high in the first week, going up to 64.8 nanogram per ml. Histopathology was suggestive of pituitary hyperplasia as well as presence of pituitary adenoma. On IHC, 80% of the tumor cells showed staining for both growth hormone as well as prolactin. In view of secondary hypothyroidism, hypocortisolism, so he was discharged on thyroxine as well as hydrocortisone supplementation and was advised to continue cabergoline, and he continued to require metformin in the post-operative period. He was also given intravenous zoledronate 5 milligram during this admission. These are the slides from the histopathology. So here we can see in the first slide, these nests of the pituitary, they have lost the reticulin framework surrounding them. So this is suggestive of adenoma. In the second picture, there are these nests of the pituitary cells. They are surrounded by some ill-defined reticulin framework around them. So this picture is suggestive of hyperplasia. So on subsequent follow-up, this patient has never gone into biochemical remission. In between, he was advised to continue cabergoline, and there was a loss to follow-up in between. And after 4.5 years during this current admission, his growth hormone was 7.88 nanogram per ml, IGA1 of 184. This normal IGA1 could be explained by multiple factors: secondary hypogonadism, hypothyroidism, and the repeat MRI cellular done during this admission was suggestive of a normal pituitary, and in the infracellular location, there was persistence of the fibrous dysplasia lesion. So besides lack of biochemical remission, this patient had now also presented with symptoms of left heart failure for 3 years. And his echo done at this time was suggestive of BCMP with an ejection fraction of 15 to 20%. He was subject to a myocardial perfusion scintigraphy, which was suggestive of reduced perfusion in the inferior wall in a part of the basal inferolateral segment of left ventricle, such that there was a presence of an 8% of the LV myocardium in the inferolateral basal segment was non-viable. CT coronary angiography, however, did not show any evidence of obstructive CAD. Besides worsening of cardiomyopathy, he was also found to have persistent hypophosphatemia. His TMP-GFR we repeated, which was again low. Subsequently, we did FGF23 levels again, which came out to be elevated, more than what was seen last time. This time it was 548.20 relative units per ml. Bone turnover markers were suggestive of increased bone resorption. This time we did, instead of MDP's bone scan, we resorted to a sodium fluoride PET scan. So this was also suggestive of lesions involving the right side of the body, the right frontal, sphenoid, right mandible, right side of the femur. But at this, there was involvement of the lumbar vertebra as well. But at this time, it also picked up lesions involving the left side of the ribs. So in the previous MDP image, there was some evidence on the right side, not on the left side. And there was also involvement of the right of the left femur in the current scan. So as far as the current status of this patient is concerned, currently he had lack of biochemical remission. He had complications in the form of cardiomyopathy, and he had persistent hormonal deficiencies with secondary hypothyroidism, hypogonadism, hypocortisolism, and there was persistence of the FD lesions with persistent FGF23 mediated hypophosphatemia. So as far as the management of this patient is concerned, so we've had a limited choice. So we've offered him IMRT, and for the interim period, we're planning to offer him medical management with SRL therapy, which we are trying to arrange. And we've also given him zoledronate injection, and the management of the cardiomyopathy has been alluded to by using ARBs, beta blockers, mineralocorticoid antagonists, and diuretics. But he's also a candidate for ICD considering his low EF and his presence of baseline VPCs. So coming to the points of discussion in this case, starting with the first point, that is the association of acromegaly in McCune-Albright syndrome. So the oldest association of acromegaly in McCune-Albright syndrome probably dates back to 1876 when Mr. Thomas Hassler, who was 25 years of age at that time, died after achieving a final adult height of around 2.35 meters, which would be 7 feet and 8.5 inches. And he belonged to Germany and was popularly known as the Tegernsee giant. The average adult height of Germans is around 1.68 meters. So it was his body, his skeleton was preserved in the University of Munich for almost 100 years. And then later on, with the development of advanced radiological methods as well as histology, the nature of his disease was characterized. And it was described as a case of polyostotic fibrous dysplasia with evidence of hypersomatotropism. But by this time, though the McCune-Albright syndrome had been described in 1936 by Donovan McCune as well as Fuller Albright, the same description was not used for this patient because the original definition consisted of a triad of polyostotic fibrous dysplasia with café and precocious puberty, which would not result in tall stature. So it was only later on that the other endocrinopathies associated with McCune-Albright syndrome were characterized. So coming to acromegaly, the prevalence of acromegaly in McCune-Albright syndrome has been considered is reported to be 20 to 30% and vice versa, 1% or less than 1%. The mean age at presentation in these cases is 24.4 years, which is younger than that of sporadic acromegaly being around 40 years. And the craniofacial effects of acromegaly can be masked by deformities of McCune-Albright syndrome. Final height is generally normal, even with precocity. Gigantism is reported in only 7% of the cases, and that happens in association with hypogonadism. And this skull-based fibrous dysplasia is particularly common. Adenoma has been found in 50% of the patients only, considering the mutation to be involved the somatotropes diffusely, and 72% of these adenomas are macroadenomas. And hyperprolactinemia has been consistently, distinctly more commonly described in setting of MAS as compared to classic acromegaly, with a prevalence reported to be 92% versus 40% in sporadic cases of acromegaly. So coming to the treatment aspects, firstly, regarding surgery, surgery has been considered to be particularly challenging because of skull-based cranial dysplasia, and also that these FD lesions are very vascular, so there may be a risk of hemorrhage intraoperatively. And the procedure of choice is considered to be total hypophysectomy, again, given the diffuse nature of the disease rather than adenomectomy. And as far as the surgical outcomes are concerned, results in these settings have been reported to be inferior to that seen in classic acromegaly. So this data of 12% control rates has come from a review by Philip Janssen, published in 2014. And this was from 25 patients of acromegaly and McCune-Albright syndrome who underwent surgery out of a total number of 112. So in that data set, 12% control rates have been described. So relatively recent data, this was a retrospective study from China. So they had 52 patients of McCune-Albright syndrome and a 25% prevalence of acromegaly in them, with 13 patients of MAS having acromegaly. 9% of these patients had an adenoma identified on imaging, and 4 out of these patients had evidence of skull-based cranial dysplasia. So 6 out of these patients achieved clinical complete remission. So this may suggest that with improvement in surgical technique over time and with the use of neuronavigation protocols, the outcomes may be actually better with surgery in these patients. Now, medical management, it's had a wide application in this setting, especially with regards to imaging negative cases. As far as the response to somatostatin receptor ligands is concerned, the response rates have shown 32% biochemical control, which is similar to sporadic acromegaly if you consider a stricter cutoff of growth hormone less than 1 nanogram per ml. And response rates have been higher in microadenomas as compared to macroadenomas. As far as dopamine agonist therapy is concerned, it's got a limited efficacy. And as far as pegvisomant is concerned, the response rates have been shown to be around 76.9%. So this is similar to the data from Acro study, which provided a real-world data of 2090 patients with acromegaly treated with pegvisomant, as opposed to the clinical trial data, which had shown a 90% rate of normalization of IGF, probably because of their stricter titration schedule. So in the algorithm of medical management, SRL therapy remains the first choice, probably because of the convenience. Addition of pegvisomant to SRL therapy, this is resorted to in the case of incomplete response to SRL therapy. So if you have a less than 20% normalization of IGF-1, and this would have the added advantage of controlling tumor growth and minimizing the frequent injections by resorting to a once-weekly protocol of pegvisomant with low-dose SRL therapy. So as far as radiotherapy is concerned, this has also been reported to have a limited efficacy. So control rates of 13% were reported in one series. And the other concern regarding radiotherapy is that of triggering a sarcomatous transformation in patients with McCune-Albright syndrome. So this kind of a transformation has been reported with a prevalence of 1%. So this is from the NIH cohort of 250 patients. But there is a little bit of lack of clarity regarding the risk attributable to irradiation. So in one series, out of 6 patients who had sarcoma in McCune-Albright syndrome, 3 cases had history of previous irradiation and rest did not. So though the risk cannot be ruled out, so if radiotherapy is to be resorted to, then it is recommended that proton beam or gamma knife may be safer if required. So in our setting, we plan to offer IMRT. So this is because of financial constraints. And the other factor in patients with McCune-Albright syndrome and acromegaly is that GH excess may be another risk factor for malignant transformation. So coming to growth hormone and phosphate and hypophosphatemia in this patient, a little bit about phosphate homeostasis. So we know that the main hormonal regulators of phosphate are PTH, FGF23, and 125 dihydroxyvitamin D. So PTH and FGF23, both of them, by inhibition of NPT2A and NPT2C, inhibits the renal reabsorption of phosphate. 125D, on the other hand, facilitates the dietary absorption of phosphate, mainly by the active route by enhancing the activity of NPT2B, and also would replenish the blood pool levels of phosphate by enhancing osteoclastic bone resorption in the setting of phosphate deficiency, which would mobilize phosphorus from the bone by means of PIT1. Now, regarding the interaction of growth hormone and phosphate, this interaction of growth hormone and phosphate is usually more apparent in the setting of growth hormone excess and also during juvenile growth. Their growth hormone would help in the retention of phosphorus from the kidney, and this is to allow adjustments to a period of excess, net bone formation. So in the setting of growth hormone excess also, growth hormone has been shown to cause an increase in TMP-GFR, thereby enhancing renal reabsorption. And this process is it's IgA1 mediated, which results in the elevation of NaPi2A, and increased calcitriol levels because of the action of growth hormone per se may contribute to the hyperphosphatemia, to increased levels of phosphate in the setting. People have tried to investigate the role of phosphorus as a marker of remission in patients with acromegaly, and it's been seen in one study that the levels of phosphorus correlate with a lack of remission also. Then acromegaly, coming to acromegaly and hypophosphatemia, as in this case, so the possibilities in this setting could have been MEN1, sporadic PHPT, or MAS. So regarding MEN1, we know the prevalence of 30 to 40% of patients with MEN1 have pituitary adenomas, with 5 to 25% being GH secreting. Vice versa, the prevalence of MEN1 in pituitary adenomas across all subtypes has been reported to be 4.8 and 7.7%. Regarding sporadic PHPT, in one series, the prevalence was reported to be 6.1%, which is much higher than the prevalence of PHPT in the general population of around 0.86% and 1.5% in the elderly. So this may reflect the trophic action of growth hormone on the parathyroid cells. The other possibility, as in our case, is McCune-Albright syndrome. So coming to the hypophosphatemia and McCune-Albright syndrome, the mechanisms implicated include GS-alpha activation in the abnormal osteocytes in the fibrous dysplasia lesions, which result in FGF23 overproduction. But this happens only if there's a substantial skeletal involvement. because along with increase in FGF23 production, there's also GS-alpha activation, which results in activation of furin, which results in cleavage of FGF23. So in order to have a net FGF23 overproduction, we need to have a substantial burden of skeletal disease. The other mechanism could be the constitutive activation of PTH-coupled G-alpha cells in the proximal renal tubule. So regarding the treatment, so this would be managed with calcitriol and phosphorus supplementation, just like other cases of hypophosphatemic osteomalacia. Regarding the role of GH control in this setting, so we know that GH excess can mask the hypophosphatemia in the setting of McCune-Albright syndrome. GH has been used as an off-label drug for hypophosphatemic osteomalacia also because of its phosphorus-retaining properties. But the other thing that merits consideration in this current case is that GH also has a role in expansion of FD lesions, which may itself result in overproduction of FGF23. So usually in fibrous dysplasia, most of the lesions are established by adolescents, and during adulthood, they may actually have a waning course. So coming back to the given scenario, this patient, he's had a lack of biochemical remission, he's had persistent growth hormone excess, and regarding the FD lesions, he's had a persistence of the same, with even new lesions apparent on the subsequent scan, with persistent hypophosphatemia, with persistent FGF23 levels, which are higher than previously documented. So this may underscore the fact that in this particular setting of McCune-Albright syndrome, the GH excess, effect of GH excess on the expansion of FD lesions may actually dominate and may result in net hypophosphatemia. So GH control, bringing down GH levels with octreotide therapy would be useful in this scenario. The other drug which has been tried for the management of hypophosphatemic osteomalacia, that is birocizumab. So this awaits investigation in this setting. Coming on to the medical management of fibrous dysplasia, surgical management can be, it's difficult, especially of the craniofacial deformities because they're subject to regrowth, especially in this setting. So medical management is directed against increased osteoclastogenesis and also IL-6 pathway, which in turn leads on to increased osteoclastogenesis. So regarding the role of bisphosphonates, they have been shown to decrease bone resorption markers, decrease pain, but no improvement in histomorphometry or radiology. The use of bisphosphonate in our current case may also raise questions with regards to the risk of atrial fibrillation, given that he has a dilated cardiomyopathy. But regarding the reports of association of bisphosphonates with atrial fibrillation, it's a mixed picture. The initial trial was the Horizon trial, which was suggestive of association of atrial fibrillation with bisphosphonates, but the subsequent Horizon recurrent fracture trial did not reveal. And studies from Europe also did not find this a significant association with bisphosphonate use in atrial fibrillation. Further, people have tried to use bisphosphonates to reduce cardiovascular mortality, given the fact that it can reduce arterial calcification, improve endothelial dysfunction. But again, in this scenario, again, no conclusive benefit has been seen. Secondly, regarding the role of denosumab, it has been shown to decrease bone turnover, but the effect of the concern with the use of denosumab is a post-discontinuation rebound. And the other concern with the use of both the therapies is the risk of osteonecrosis of the jaw. So in one series, it's been reported that in the setting of fibrous dysplasia, the risk of ONJ can be as high as 5%, which is much, much higher than what is reported for the use of bisphosphonates in the setting of osteoporosis. So this may be actually similar to the risk of ONJ that is seen with bisphosphonate use in the setting of malignancies, where they report the risk ranging from 1 to 10%. And regarding the role of targeting IL-6 pathway, so tocilizumab has been reported to be useful in case reports. There is another study which is ongoing, and the results of the same are awaited. So coming to the conclusion, so acromegaly has a prevalence of 20 to 30% in McCune-Albright syndrome. Diagnosis can be delayed, especially by craniofacial dysplasia. Management of acromegaly can be challenging given the difficulty of surgery, as well as the limited efficacy of medical management and the controversial role of radiotherapy. GH control in the setting of hypophosphatemia represents a double-edged sword, but where do we tip the balance? Given the effect of growth hormone on expansion of the FD lesions, so this would favor targeting a low growth hormone level in these patients. Thank you.
Yeah, I think that was a very good case. I think many of the questions have already been answered. Majority of them we wanted to ask. is there any cutoff for the skeletal involvement above which you find that the phosphate levels go down? Because as you know, growth hormone stimulates phosphate, as you are already told. So percentage of bone involvement and phosphate levels, anything like that?
As far as the quantification of the skeletal, as far as this quantification of the skeletal lesions is concerned, previously we've been doing MDP scans. With that, we get to know only an idea of the extent of the disease. But with the newer scans, that is fluoride PET scan, which is done with a PET CT, so we can actually quantify an SUV. So these SUV values have been shown. With this, they've tried to come to the calculation of lesional activity of the lesion. So with fluoride PET scan, we can actually calculate the skeleton burden more appropriately as compared to the skeleton burden scores used for MDP scans, because it was only based on visual assessment and would show the extent of the disease. But quantification of the lesional activity can be better done on fluoride PET scans. So for this, we can, I think it requires studies. So this can be out of future investigation. In fact, with denosumab, there's one recent article in JCM where they've tried to calculate the scores with fluoride PET and then see the effects on follow-up.
Sir, please.
So there's a lot of questions. Let me first congratulate you for presenting a very difficult case very nicely. There are a lot of theoretical questions, but I just a couple of clarifications. The bone scan in the beginning, I thought I could see a lot of kidney, right?
Yes.
You normally would have expected with such extensive skeletal disease to have a much more suppressed renal uptake. Is there an explanation for that?
So that's a physiological uptake. I'm not sure of that.
Because there is extensive skeletal disease, and the classical metabolic super scan, one of the first things that get hits is a reduction in renal uptake. So I was very intrigued by that. Secondly, my second question, which actually Dr. Ashu Rastogi has also asked is, you said that the patient underwent a total hypophyseectomy, whereas in your follow-up scan, you refer to the presence of a normal pituitary. So again, I'm a little confused there. If there was a total hypophyseectomy, why is the pituitary still visible?
Yes, sir. Yes, sir. So it was a total hypophyseectomy as per the surgeon and the intraoperative findings. But given that the subsequent scans have shown the evidence of normal cell-up, so the extent of resection might not have been complete.
No, that's pretty obvious, right? There's so much pituitary still visible.
Yes,
the extent wasn't there.
Yes, sir. Yes.
Okay.
Yes,
so Dr. Ganpati, do you want to take over and do the other questions in the chat box, the ones which haven't already been answered in the...
From Professor Martha Carbonates, how does GNAS mutation lead to high FGF23 production?
So the activation of GNS mutation will result in activation of GS alpha subunit in the abnormal osteocyte seen in fibrous dysphasia lesion. So it's basically the abnormal the bone marrow stromal cells cause the development of abnormal osteogenic precursors, which give rise to abnormal osteoblasts and normal osteocytes. So in these, constitutive activation of GS alpha has been shown to increase FGF23 overproduction.
Okay. Did you think about the role of SGLT2 inhibitors for this patient with heart failure? Is there a role for that?
Yes, we can definitely include SGLT2 in this setting.
I think Ganpati, there may not be the data for that, but I think even they are useful in a patients with heart failure as a general.
Yes, now they are used.
So they can be used.
So my question here was, what is the etiology of the low ejection fraction? Are we considering hypophosphatemia as a significant contributor? And if we are, in the absence of doing anything, I realize that there are limited options available, but have you tried phosphate replacement and seen the response to the phosphate replacement?
So we have recently started him on phosphate replacement. So it was the current admission right now in February that we diagnosed him to have been advanced stage of acromegaly cardiomyopathy. We've started him on phosphate replacement. And the other thing is that he's had a long-standing burden of disease. So this had his height gain, excessive height gain was noticed around 10 years of age. So he's had almost more than 20 years age of 20 years duration of growth hormone excess. So in this and at presentation at 37 years, he already had evidence of stage 2 cardiomyopathy with evidence of left ventricular hypertrophy. So given this long-standing duration, he could have, and lack of biochemical remission, so there was a possibility that he could have had a decompensation and he could have progressed to the advanced stage.
Sure, I totally understand that. But since you have limited therapeutic options for, undoing 20 years of growth hormone excess, then you may as well try and do what you can do rather than only speculating on something which is possible, but, is something which you cannot target at this point in time. There are a couple of questions in the chat box about IMRT. The pros and cons of using IMRT in the presence of FG, and is it at all recommended in the presence of sphenoid bone dysplasia?
It is not recommended, as I pointed out, because of the potential concern of sarcomatous transformation. So here we are, so given this confusion regarding radiotherapy, what is recommended is that we can go for a gamma knife and proton beam because they're much more precise. But the problem here in this patient is that there were logistic issues. So that is why we've resorted to IMRT in this setting.
I think in the interest of time, we should wind up because we have the next session.
Can I congratulate Jasmeet Kaur? I think it was like a PhD defense the way that she got questioned, and I think she really answered very well. So Jasmeet, if you are hearing me, congratulations. Very well presented and very well defended.
Thank you, sir.
Very well, yes, very well presented.
Thank you, sir.
Okay. Over to the organizers for the most important topic also for today from Dr. Maria Flesidu.
Thank you, sir. Thank you, Dr. Jasmeet and chairpersons for the very interactive session. From now on, we move on to our final session. For this, I would like to invite our chairpersons, Professor Jamal Ahmed, Professor, Department of Endocrinology, AMU, Professor Anil Bhansali, Professor, Department of Endocrinology, PGI Chandigarh, and Dr. Sharik Masoodi, Professor, SKIMS, Srinagar. I would like to request chairpersons to kindly introduce our next speaker. Thank you.
Should I introduce, or Dr. Jamal is?
Sir, you go ahead.
Yeah. So it's a pleasure on the behalf of my co-chairpersons. It's a pleasure to introduce Professor Maria, who is a professor of medicine and neurological surgery at the director of the Pituitary Center at Oregon Health and Science University. And she has been the immediate past president of the Pituitary Society. She has more than 200 publications and many consensus guidelines on that. And she will be talking about the consensus guidelines in Cushing's. And as the patients with Cushing's, they do have so many comorbidities. So what are the guidelines for managing these patients preoperatively, intraoperatively, as well as postoperatively? So she'll be talking about these. Professor Maria, please.
Thank you so much for inviting me to such a great conference yesterday and today. Congratulations to all for the Golden Jubilee, and to the residents for excellent case presentations and great presentation skills. So you'll be great endocrinologists. I'm going to try and share my screen. Hopefully it works. It worked yesterday. Can you see my screen now? Okay, perfect. So I have been invited to talk about complications, consensus, and controversies. As you all know, for Cushing's is going to be more controversies rather than consensus per se. These are my disclosures, both as research funding, everything goes through the institution, and scientific consulting fee for the study design or steering committee. And this is a very timely presentation, and the conclave itself was very close to Cushing's days. And I just wanted to remind you that was more than 100 years ago. And did we make a lot of progress? Yes. Did we make enough progress? Clearly, no. Look at first patient mini-G. We still have many patients that still present, as you've shown with beautiful cases earlier, very late in the course presentation, and nobody even thought about Cushing's per se. And because of that, patients with Cushing's, as you have alluded in some cases, at presentations have already many comorbidities and clinical complications. Some are well known as neuropsychiatric disorders, atherosclerosis, liver steatosis, and NASH. That's becoming more important lately for a lot of other diseases, osteoporosis and myopathy, and some others as cardiac disease and hypercoagulability that are trying to be more progressive and more aggressive in finding the disease itself and also in how to manage overall. And of course, you already talked about infection. I had several slides and I'm going to briefly go about it because you already did it very beautifully. So when we're talking about complications, because a lot of diseases have some complications, how we compare them as a magnitude for general population. So you see here in blue is Cushing's disease, and in red is general population. So if you're looking at the prevalence, overweight and obesity, it's relatively similar, but look at the hypertension here, look at the impaired glucose tolerance and diabetes, major depression and osteoporosis. So we're talking about many, many times over compared with the general population. And because of that, we know that patients with persistent Cushing's disease have significant higher both morbidity and mortality compared with the patients in remission. And this data that I'm showing you was from 10 years ago, so with studies even older, and then I will show you later now. But if you're looking at the patients with persistent disease, the SMR for mortality was more than 5, and with remission was a little bit better, but still not normal. So are we doing better now? We don't really know, and I will show you some recent data. And the problem with that is because there are several things that contribute to the morbidity and mortality. So patients could have severe osteoporotic fracture, and that's increasing mortality per se, the opportunistic infection that you showed earlier, and a lot of cardiovascular complications, including hypercoagulability, and we have some new data on this, coronary heart disease and cerebrovascular events that sometimes can go unnoticed. So should we reverse? Yes. And how to do it? That's when it's becoming controversial, because we go into a multidisciplinary effort that we should definitely work more with cardiologists on that. And the main reason why we didn't make a lot of progress, in my opinion, is related to the fact that the reversibility of complications depends on how long they are. So if a patient has, like you showed for growth hormone, it's almost the same thing. For Cushing's, it's even more. If they had Cushing's for 20 years, then the cardiomyopathy and a lot of the other complications, including on the bone, on the brain, you know, it's shrinking per se, is going to be much harder to reverse or even decrease if compare with patients that are diagnosed very early. So we still have to move to an early diagnosis and prompt treatment immediately. So where are we now? This is a paper from a single center. I'm going to show you some multi-center also, published this year from Vienna. And they looked at factors associated with mortality in Cushing syndrome, but also they looked at complications, and especially acute and life-threatening complications. So if you're looking, these are the patients with any complications versus these are non-survivors in gray, and these are survivors in still gray, but a lighter gray. So the main issues that the patients had were, again, infection, that's almost like a leitmotif. If they were in ICU, hypokalemia and pulmonary embolism. So the rate of pulmonary embolism, as you can see, they were pretty high, and this is much more recent data. If we're talking about multi-center data, and usually I like the larger centers, single center, because it's a more unified approach, but this was overall, though, with different methods of treatment and from countries to countries, but that was a very large European database of over 1,500 patients. Most of them were pituitary dependent, some adrenal, and few ectopic and other causes of Cushing's, followed for almost 3 years. And they were, mortality was 3%. And if you're looking, very important, and I think that's where we should manage much quicker, 45% of deaths occurred within 90 days from start of treatment, and 10% of deaths occurred even before the treatment was given. So we have a lot of cases of severe Cushing's, and we need to really look into more aggressive treatment initially. And as you heard earlier, the most common causes of death in that larger center were also infections or progression of underlying tumor, because this included also the ectopic Cushing's. But infection, 37%, and this was a study done in Europe, where overall the rates of infections in general populations are not very high. Very interestingly, the older age of diagnosis of active disease predicted long-term mortality, but the male gender and longer duration of active Cushing syndrome that we think, because they have sometimes more ectopic or more duration overall, did not have impact directly on mortality. Clearly it has on complications, but for mortality in this study was not shown. Furthermore, if we're talking about how long they persist about remission, this was a large single Swedish national patient registry, over 500 patients. This was pure Cushing's disease, so forget about ectopic or other causes. And if you look in blue is stroke, in red thromboembolism, and in green sepsis, this is before the diagnosis. This is from diagnosis until 1 year after remission, and this is long-term remission. Look, compare with one, all of them were still high, and this excludes, as I said earlier, patients with other causes of Cushing's besides Cushing's disease. So stroke is high, thromboembolism is high, and sepsis was also very high, even in long-term remission. Now, there is data from UK. This is a little bit older, but I just wanted, because that's the first time I'm mentioning diabetes and the last time almost for today, because we need a full talk just on the diabetes and Cushing's. But I wanted to show you that this is very beautifully shown by Clayton and all, that patients that did not achieve remission with Cushing's disease clearly had higher mortality versus remission. But then if we're separating them by no diabetes and diabetes and no hypertension and hypertension, the curve separated significantly. So it's important, one, to be in remission, but also the type of complications and how well they are controlled. It's also very important. More recently, though, we all knew that it takes a while for patients to go back to almost normal. This is a study several months ago in GCM about muscle function. So there are a lot of patients followed over long term with Cushing's in remission with easy chair rising tests, grip strengths, and all their other complications. And as you can see, so this is a chair rising test in seconds. So the higher you are, it takes you more to get out.
Ma'am, you need to unmute.
Okay, so the chair muted. Sorry. Can you hear me now?
Yes, ma'am.
I don't know. I muted me. So the influencing factors for myopathy were age and A1C, and as we can think, the waist to hip ratio was very important. So patients that were more obese, but specifically not just BMI itself, as waist to hip ratio had higher delay in recovery on muscle function. And then there is some data that's pending on the role of growth hormone deficiency related particularly to that muscle function. However, we have data from the HYPOC study. This was a long-term study on patients with growth hormone deficiency treated with growth hormone by one of the companies. And this particular study looked at comparison in patients with Cushing's and non-functioning adenoma treated with growth hormone. And briefly, if you look, this is metabolic syndrome, this is diabetes, cardiovascular disease overall. And in black is Cushing's disease, and in gray is non-functioning adenoma. So if we're looking, these are all treated with growth hormone. If we're looking at 3-year incidence, and it's pretty much the same with prevalence too, clearly patients with Cushing's had more metabolic syndrome, more diabetes, and more cardiovascular disease compared with a non-functioning adenoma, despite the fact that they were treated with growth hormone. So previous Cushing's may predispose the growth hormone deficient patients to an increased risk of all these complications that are not reversible with growth hormone treatment, though this, and could be a different discussion, we still have to treat some patients with growth hormone because otherwise complications could be even higher. So let's briefly go through a case relatively similar to what you have presented and see what should we do for this patient. 55-year-old female with 4-centimeter pituitary macroadenoma discovered during hospitalization for diverticulitis. She had 2 bouts of diverticulitis with sepsis, liver abscess, portal vein thrombosis treated with warfarin, hypokalemia, worsening diabetes, hypertension, central weight gain, and hyperlipidemia, weakness, non-displaced pelvic fracture. She was using a wheelchair, and they did imaging in the outside hospital, and they found a large pituitary tumor, and this is why she was sent to us. So the labs on the left are our labs. This was the tumor. Based on everything you've seen before, she was sent to us without a diagnosis of Cushing's. She was sent to us to evaluate for the large cellular tumor with no mentioning of Cushing's. Though, as you have seen, there are probably 20 reasons why she should have been checked for Cushing's. So the labs were clearly consistent with very severe Cushing's, as it was clear clinically. So what should we do? This is a recent review that we looked at all the literature on concomitant assessment for comorbidities that was published in EGE last month. And I wanted to point out, and I will go separately by it, we should probably, for the patients I showed you, do everything in the same time: cardiovascular assessment, thromboembolism prevention, and infection prevention. And I'm going to enlarge and show them to you one by one. So cardiovascular assessment, I showed you that the cardiovascular disease is the main cause of death with infection. So we should initiate prevention and treatment as soon as we think about treatment for Cushing's. And sometimes depends where the patient goes. If they go to neurosurgery for a tumor, like last patient I've shown you, sometimes the cardiovascular risks are pushed until after. But this is why one of the main reasons why the mortality could be increased. So let's go and look a little bit of some of these risks and what can we do about them. So the heart failure, it's very prevalent in Cushing's with left ventricular hypertrophy and atherosclerosis. You know that on the right, you can see the increased intima media thickness. The increased risk of myocardial infarction is very high, and the increased risk of stroke is very high. So this patient will go to surgery with a very high risk of several deadly complications overall. How about hypertension? So what I wanted to point out, and sometimes our fellows don't think about that, is that hypertension is very, very frequent in Cushing's, does not correlate very well with the degree of hypercortisolism. And furthermore, though we say that it doesn't correlate with the degree of hypercortisolism, a lot of the effects are due to mineralocorticoid effects when the cortisol is very, very high. So we have to think when we're thinking about treatment that a lot of the hypertension is related through mineralocorticoid effects, including renin-angiotensin system, sensitivity increase to beta receptor agonists, and vasoconstriction overall. How about dyslipidemia? A diagnosis of Cushing's, we know that we have low HDL, high LDL, and high triglycerides. And it's seen in up to 50% of patients depending on population and with multifactorial causes. Importantly, if you look at the studies looking at disease remission after surgery, and we'll talk about medication separately, though they are pretty similar, the hypercortisolemia resolution has mild or no impact directly on lipids. So that's very important that we shouldn't wait for the Cushing's to get better. If there are abnormalities, especially after surgery, we should treat specifically as we treat any high-risk patient overall. And now let's move on to the hypercoagulability. This is a systematic meta-analysis that we published in 2019. So we looked at all the data until I think, early 2019, if I remember correctly, there was not a lot of data. So we should all get together and actually publish way more cases and studies, because here we included everything that was available and published. And there were 48 prospective, retrospective, cross-sectional case series, cohort or survey studies. The single study reports we excluded. And we found that 3.21% of Cushing syndrome experienced venous thromboembolism. Here, it was just venous. I'm going to show you some data with mixed. And the odds ratio was almost 18% compared with general population. The only good thing is, because when I was looking for some control in my mind, I was thinking patients, at least in US, patients that have hip fracture have to be anticoagulated. So where are we overall with the risk of hip fracture? So the odds ratio for perioperative VT in Cushing's were a little bit lower than, but without anticoagulation versus hip fracture surgery. So at least we're doing better with something, but compared with normal population, still very high risk of complications. When we look at our data, we looked at over 200 patients. 25% of these were, because this was over time, as you can see, lately we anticoagulated more. So some of them were anticoagulated. 18.2% had arterial and venous thromboembolism overall. There were a lot of events. So this is 60 days after surgery. For most patients had some sort of surgery. We found no predictive factors, no sex, no BMI, no smoking that we thought it is, no high cortisol level or estrogen or testosterone therapy. Almost half of the patients, though, underwent at the time of thrombotic. So,
can you please unmute somebody?
What are the causes for
Everyone to mute.
thromboembolic events? It's very, very complex, and I'm not going to go one by one. I want you to have this in your mind, because there are some things that maybe we can look at and decide if these are higher risk patients or not, that we have no clear data. And furthermore, I wanted to point out that after surgery, even in patients with immediate remission that can increase the inflammatory response, the patients actually can have higher risk. So we have to think that patients with active Cushing syndrome have risks. The postoperative phase have even higher risk, clearly, though we're trying to mobilize them. But overall, anything that's with surgery, it's increasing the risk, even without Cushing's. And then in disease remission overall, there are some patients, as I've shown you in our data, that could have events much, much later. So this was a study in 2018, just showing you briefly that you can have, these were endothelial damage cells, VCAM, you can have even longer term. This is control, this is active, and then this is remission. You can have persistent inflammatory damage that could be even years. Now, should we anticoagulate everybody for years? I don't think so, but we should really have high awareness that these events could happen. So overall, how I look in my mind is, do we have any risk factors that we know of? And you see here on the left, from if it's ectopic versus Cushing's disease, if they had a prior DVT, and the risk factors that we know overall. And then non-pharmacologic methods in everybody. And then consider, and this is considered because it's the risk of bleeding and it depends with which surgeon we're working, but at least consider starting pharmacologic prophylaxis after uncomplicated surgery, and then continue for 4 to 6 weeks after surgery if there is no increased bleeding risk. In high-risk severe Cushing's, we should probably consider prophylaxis even prior to surgery, and then depending on what they are on, to just make a bridge throughout the few days before and immediately after surgery to decrease the risk of bleeding. So if you're asking me, and I can't see the chat, but if you're asking, should we anticoagulate everybody? Clearly not, because there are some patients that have higher bleeding risk. Do we have perfect risk factors assessment? The answer is no, and the Cushing's consensus is not published yet, but I can tell you from the meeting that it was not a full agreement. What would you use and for how long? I showed you that there are events up to 3 months. Probably after bilateral adenectomy, I'm extending from 6 weeks that I use now to even longer. For all the others, should probably be 2 to 4 weeks. And then there are some cases that showed DVT or other events after IPSS. Should we anticoagulate for IPSS? That's not our procedure right now, but might be something to think about. How about infection prevention? You went very nicely through the high risk and what are the mechanisms. So here I just wanted to bring up that we should probably consider starting prophylaxis for everybody with very high urine. As it was shown, it's not a lot of data besides Dr. Niemann's study that was linked to UFC over 10. I think the duration of the disease plays a role too, because if you're immunosuppressed, you can be 6 over upper limit of normal, but then if you are for many years, you can be more immunosuppressed, and if you have diabetes in the same time. Definitely, again, it's very important to consider the higher risk after curative surgery, because the decrease in cortisol is actually increasing the risk of PCP, and then, of course, address the risk factors for all the infection. Other things that probably we are aware, but it's not something that we can do too much about it, but it's very important for the patient, is the quality of life. So we know this was a study on generic questionnaires for patients with cured, so-called, because that's definitely, it's no cure for Cushing's, it's just remission. And if you look at several factors, both for NHP and for SF36, just look at the colors. Patients with cured Cushing's, it's in orange, healthy control in blue. If you look from physical functioning, social functioning, emotional, pain, general health, and health change overall, everywhere they were lower on the scale. And these were patients with so-called cure. So definitely we're not doing a good job in reversing the patient's quality of life or the complications for that matter, as I showed you, to normal. How about bone? So we know more that Cushing's, it's causing osteoporosis, we knew forever. Now, what's more recent, and this is not just for Cushing's, it's for acromegaly and for other pituitary disease, is that evaluation of bone health should be done as a continuum and not just as a DEXA, because the DEXA scan do not predict the fracture risk. So we need a morphometric analysis. And you've seen for prolactinomas, for acromegaly, we can see vertebral fractures on X-rays that are in patients with normal DEXA. And then it's a question of when should we use anti-resorptive treatment with a biphosphonate? And it's possible in some cases that don't have contraindication that they might induce a more rapid improvement rather than cortisol normalization alone, though there's others that are saying, talking about controversies, that you have to wait at least 2 to 3 years to see if the bone density does not become normal. So this is in general about complications and how to follow the patients, but are we achieving, and with some of the updates on what happens after remission, thinking about surgery. How about medical treatment? Because right now, at least in US, a lot of patients, and I will show you even in Europe, up to 30% of patients are treated with medications for Cushing's, and some of them even did not have surgery. So reversal of clinical feature is very important in addition to the biochemical normalization. And of course, ideally, we will not have recurrences, though, you know, in Cushing's disease, it's happened in up to 30% of patients if we follow them long enough. So when we think about treatment, I usually use surgery as first line, as I showed you earlier, and use medical therapy as an adjuvant treatment with minimal exceptions unless the patient has complete contraindications. However, when we choose a medication, we should look at, of course, medical history, side effect profile, cost and availability, and the cost is becoming a huge issue, patient wishes, but also comorbidities. So what's the data on each drug, what's improving, and what makes it worse? And especially in Europe, in US it's done less. The preoperative medical treatment is used to optimize severe comorbidities, like in the patient I showed you, diabetes, hypertension, hypokalemia prior to surgery. However, there is no data that it's improving outcome overall. You can delay the surgery and improve the diabetes and the hypertension, but even the Ercusin data did not show that you improve overall outcomes longer term. So if you can optimize very quickly, yes, if not, treatment of Cushing's should be done in the same time. And of course, it's confounding the assessment of early post-op remission. So when we look about drugs, and the talk is not about drugs in general, it's just about clinical effects, but I wanted you to think about, because if it's a large tumor, then yes, we might want to use drugs that work at the pituitary level, but we have to try and find out what we achieve with that. We have drugs that are working at the adrenal level, the adrenal steroidogenesis inhibitor, and the only one approved in US is osilodrostat, but we have all the others or in clinical trials or off-label, and glucocorticoid receptor blocker that in US it's approved for hyperglycemia associated with Cushing's. So for pasireotide, we have sub-Q and LAR, and they work rapidly. However, it's controlling around 50% of mild Cushing's. For severe cases, it's hit or miss, but it's improving the clinical signs and symptoms in a lot of patients, and it's inducing tumor shrinkage. So for some patients that don't have diabetes, and I will show you why, this would be a good first-line treatment to try and shrink the tumor and see how they do. However, the blood glucose level should be monitored very, very close, because patients, if they have Cushing's, the likelihood of worsening hyperglycemia with pasireotide, it's over 60%. And we know now why, because the pasireotide inhibits both the secretion of insulin and the release of GLP-1 and GIP. So it's a more confounding factor. And also what's interesting, as you heard yesterday from Dr. Mehmed, we're using pasireotide for acromegaly. For Cushing's, pasireotide is inducing even more hyperglycemia. The reason I brought up the pasireotide data is to show you mostly that this is the longer term data that we have. We looked at this paper for a while before we published it at every predictor possibly. So what you have here are all the patients in the study that were treated long-term. And you see in blue, keep in mind that in most of the studies I'm showing you, the urinary free cortisol was the endpoint. So this was set up as normalization required by the FDA, but in general, this is still considered the gold standard. So if we're looking at patients that had controlled just the urine, this was 28%. If we look at a patient that had both, this is in blue, both UFC and salivary cortisol controlled, this was less. But if you're looking on the right on clinical improvement, look at how much is the difference on systolic blood pressure, diastolic blood pressure, and weight if we had both of them controlled. So this makes sense. There were no other predictor factors, not age, not sex, and all that. We looked at all this. So the idea is maybe when we're using medical therapy and using just the urine as a marker, this is not enough, and we should restore the HPA axis, the ioronal variation if we can, or use in a different form to try to improve also the clinical features more. So osilodrostat has been FDA and EMA approved last year. It's an oral inhibitor of 11-beta hydroxylase, and also it's inhibiting aldosterone synthase. And the paper for phase 3 was published late last year. And overall, this is a very powerful medication. As you can see, this is week 12, week 24, and week 48, with in red complete response and in green partial response. The over 66% of patients maintain normal UFC levels at least 6 months. And everybody, these were several means, almost everybody, 96, had at least one urinary free cortisol normal, but then it went up or down. So that's very interesting how when you look at control, you realize that some patients sometimes will be too low, and this study had significant adrenal insufficiency, and makes sense. If you block too much, then you'll be insufficient. If not, you'll get a little bit over high at some point. How about clinical improvement? Because this is the goal to look at today. So the systolic blood pressure, the diastolic blood pressure, weight, waist circumference, glucose, and A1C improved. Furthermore, the mean percentage changes for Cushing's quality of life and depression scores were also improved. So if we're looking at these were all significant and statistically significant, but when you look at clinical overall outcome, we need more longer term data to look and see the improve, for example, in glucose. Yes, it was significant, but can we achieve it with a diabetic medication and use lower dose of this drug that's more expensive? However, what are we doing with the Cushing's symptoms per se, including the quality of life, depression, that a diabetes medication is not going to improve? So we need more longer data to look at that. How about levokitoconazole? So the phase 3 prospective studies was done in several countries, a lot of them in Europe. And this was published earlier last year, a little bit before the other paper. And the UFC normalization at 6 months with imputation was 42%. And I'm using with imputation just so you can compare with all the data that I've shown you earlier. Showed improvement in cardiovascular markers. Testosterone decreases in women and acne improved. So that was good. But I'm going to show you the data. Significant from graphs, but is it significant from clinical point of view? For some patients might be. The liver enzyme elevation was seen in 31% of patients, and 11% and patients had elevations more than 3 times upper limit of normal, a little bit better than ketoconazole, but still significant. The good part was that was reversible after discontinuing the drug. So I have here on the left how severe the Cushing's was. So look at the patients, most of them are Cushing's disease. The baseline mean UFC was over 5 times upper limit of normal. So severe patients. And this is where I said earlier, these were patients that were completely treatment naive. They didn't even have surgery in almost 30% of patients. So if you're looking at clinical features, I'm not showing you the cardiovascular markers because they were statistically significant, though I don't know if we can say that from clinical point of view, they are significant. The acne improves though, and the patients are looking at that. The testosterone and the hirsutis total score in women decreased. So overall, the same feature for Cushing's quality of life and depression score. So we see some changes, but we have to decide how relevant they are overall. How about the glucocorticoid receptor blocker that's approved in US for hyperglycemia associated with Cushing's? It's not approved in Europe and in other countries as far as I'm aware, but it's used off-label. So the doses varied. We saw improvement in glucose. That's why it was approved for that, but also clinical signs and symptoms. However, you can measure cortisol. A lot of patients had adrenal insufficiency, does not control the tumor volume, and the thyroid function needs close monitoring, both for primary and for central hypothyroidism. We recently shown that. However, if you look at the diabetes, this is A1C baseline, week 16 and week 24. This improvement was despite even decrease in medications for diabetes. And then what I said earlier, clinical improvement. So we looked in this study at weight changes, diastolic blood pressure, 2-hour OGTT, and Cushing's appearance. In red is much improved, blue is no change. So some patients improve significantly, some patients no change, from diastolic blood pressure to OGTT that are more objective, and Cushingoid appearance and how they felt and what they were telling us. So not everybody is going to improve. So when we use a drug, we should know why we're using it. The way that was really, this is the graph on weight, it's percentage change, but if you're looking, this was about, they started at around 100 kilos. So it's also very significant decrease in weight. And what was important was the decrease in waist circumference was also very good for patients that I showed you that the waist circumference per se was correlated with a lot of the complications. that depends also, that doesn't mean that because we want decrease in waist circumference, I'm going to start this drug that costs over $500,000 per year, for example. But we need to know which drug is doing what. So in summary, complications should be addressed and screened for immediately after diagnosis. After treatment for Cushing's disease, the cardiovascular risk factors and manifestations persist at various rates. So we should know and tell the patient. And I usually tell them that you have to be followed forever. The risk of recurrence is 30%. You might have even more complications that you didn't have before. And I usually mention the heart attack and the thromboembolic events. Active Cushing's disease has even more adverse impact on survival, and mortality after remission, as I showed you, it's affected by various confounding factors. So some studies show that we are almost back to normal, and probably these were the single center studies that are using aggressive management of diabetes, cardiovascular disease, and hypercoagulability. And the minimizing duration and extent of exposure to high cortisol by early diagnosis and rapid effective therapeutic intervention and systematic monitoring with tight control of all the risk factors I showed you earlier and put them in balance with the pros of using additional treatment. I didn't show you data for bilateral adrenectomy or radiation to cure the patient earlier, or everything as a multimodal treatment to get back to normal, but looking at the complications in the same time. So each patient is different and require different set of treatment. So overall, you have on the left patients with persistent disease after surgery stratified by individual clinical attributes. From a paper from Monica Gadella looking at predictive factors overall. This applies to acromegaly, this applies to Cushing's, I slightly adapted for Cushing. So we have to look at comorbidities in parallel with biomarkers and disease characteristics to try to find the right treatment for the right patient. Thank you so much. And you have on the left my clinic, that's Mount Hood. And the hospital is up, so we'll take the train to go to the hospital. And on the right, my hometown city in Romania, Sibiu. I'm from Transylvania. So I guess I'm a vampire. Thank you so much, and looking forward to meeting you one day in real life.
Yeah. Thank you. Thank you, Dr. Maria, for very nice and lucid presentation. And talking about a lot of comorbidities which these patients of Cushing's have, as well as their treatment strategies. I think Dr. Masoodi can take the questions now.
Yes, I don't see any questions in the chat box, or maybe they are not.
There are a few questions, Masoodi.
Okay. So, yes. So can Dr. Rahul ask the question himself?
Yeah.
Is Dr. Rahul available? Okay, Rahul says, will it be right to say that long-term outcomes in Cushing's disease are determined by the duration of hypercortisolism, associated comorbidities, and how rapidly we control it instead of the type of modality of treatment?
So that's a very good question. Thank you for it. And I thought I made it clear that, yes, that's the most important factor. However, if you look at the data, for example, on quality of life for surgery, patients that are in remission after surgery, they have higher quality of life than the patients that are on medication. And that makes sense because you have prolonged disease. And of course, if you take more medications, it's more costly and it's perceived lower quality of life. So I think the focus should definitely be on early diagnosis and how to increase awareness and to have this diagnosis much earlier. We're working for many, many years on that, and we're improving, but not getting there. As you've seen all the studies from Ranke group, it's still almost the same delay of diagnosis. And in the US, it's the same thing. The type of treatment, what I wanted to, and I brought up some of the new data, is that we should think about that also of what each treatment can improve when we choose it based on comorbidities, but not that one treatment is better than the other as long-term outcomes for mortality. We have no data on that. I'm hoping that now we are using some of these drugs for more than 10 years in larger studies, so it's possible we'll have some data at some point.
Thank you. Another question is, does keeping 24 hours urinary-free cortisol as the only target of treatment negates the role of CRH, ACTH play in normal homeostasis or so-called citrus response?
That's also a very good question. And I didn't have time to go into all that. And the UFC is the endpoint for the clinical trials. So definitely that's why you see all the curves with UFC. In my practice, I always look, of course, at UFC, but I look at salivary cortisol in all the patients that are, of course, not on mifepristone because then you can check cortisol, but I'm trying to normalize. So for example, for adrenal steroidogenesis inhibitor like osilodrostat, I always use higher dose at night. I look at the comorbidities. So for example, if a patient has normal urinary free cortisol, but otherwise still doesn't feel good, and I have room to increase the dose, then I will do that. For example, causing adrenal insufficiency. If, for example, a patient is doing well and the UFC is almost normal, but the salivary is not, then I will try to add the medication. Hypopituitarism, for example, I didn't show you all the data on combination. So definitely not just the UFC. It's now the bug, not the feature, because that's how all the clinical trials are set. And I'm hoping that we'll have more clinical endpoints, but at least until now, the FDA is very strict and they want biochemical normalization. But I'm always, the same thing as for acromegaly, I'm always a proponent for combination of, yes, numbers are important because they have been linked to mortality. However, how the patient feels, to have pure patient-reported outcome would be significant because from our point of view, sometimes the patient is doing better, but they say no. And then looking at all of this in tandem.
Thank you. Dr. Harish wants to know, do you check suppression of cortisol as a test to check the relapse of Cushing's disease post-op, or it is only UFC?
That's a very good point. And USC is probably the last one that is going to become abnormal in recurrence, not in all the patients, if it's full-blown Cushing's. So overall, the many studies, and in my experience, the late-night salivary cortisol, especially if it's done in a good assay, it's the first one that will become abnormal. For some studies, was even with a year before. After that is probably the overnight DEX, pretty close, but I was thinking if I can give you a timeline, but we don't have that because just one study look at that. For salivary, we have several. Let's say usually it's about a year before abnormal salivary and then abnormal urine. And the overnight DEX is somewhere in between. But yeah, I don't do routinely UFC. After the patient recovers, assuming they had successful surgery, I put them on steroids, slowly taper. After they're normal, I tell them in advance, if you're normal, I'm happy, but doesn't mean I'm happy forever because your disease might come back. So once they're normal and off steroids about 6 months, I do some baseline serial salivary cortisol and then base additional testing.
Thank you. Dr. Badada wants to know why rate of infection is high even after long-term disease remission.
Thank you. I would like to know that too. Nobody really knows. Is this with a frailty of patients? Is this because something in the immunity changed forever because they had Cushing's for 10 years? We don't know. But that's a very good point. And we just I can't hear you.
Please unmute yourself.
May I add?
Yes, sir.
Hello.
Yes, sir, we can hear you.
Yeah.
We can hear you now, sir.
Okay. I think it may be the long-term, the bad legacy effect of the glucocorticoids, the prior glucocorticoid exposure, still predisposes them for many comorbidities. That may be the one reason for that. And secondly, I think majority of the patients, despite of a remission of a disease, they are on supraphysiological doses of glucocorticoids. That continues to them predispose for most of the comorbidities, even after curative surgery in these patients.
Oh, definitely, you are correct. I assumed that the question was related why long-term later on after they're off steroids. You're right. Immediately after surgery, when they're on supraphysiologic, it's a totally different story. But what's interesting is the risk of infection persists even after that longer term. So we don't have the answer, but definitely many years of Cushing's and then sometimes a year of excess glucocorticoids can do that too.
I don't see any more questions. I have a question. How about managing Cushing's during special situations like during pregnancy or in children?
So that's very interesting. I'm not going to comment on children because we don't really have a lot of data besides the NIH. We're going to briefly cover it, and we're not seeing children directly. So we usually send them to NIH if they're more than 16. For pregnancy, we'll briefly cover in the new consensus, but again, that's not something that I can say I'm an expert. I haven't treated the child since I left Romania, so that's more than 20 years ago. However, for pregnancy, none of the medications that I've shown you are approved. There are several case reports of using metirapone. And overall, that was pretty safe. I would not use it if I know that the patient will want to get pregnant, but if a patient develops Cushing's during pregnancy, we did in second trimester some transsphenoidal surgeries in patients pretty safely. But in my view, for patients that have Cushing's that's failed surgery, and if they have recurrence and they're planning fertility, I think that's probably my to-go treatment for now. It's still bilateral adrenectomy because that's when they do the best in pregnancy. And I think with this, it's pretty much an agreement for everybody that until we have anything else that's better, probably is the safest one.
Right, thank you. I would like to know more about this hypercoagulability in Cushing's. As you said, we don't have much data. We don't know who is going to develop hypercoagulation, who not. But at least, do you recommend screening every patient for hypercoagulability, and what tests we should do?
So I don't have the answer because we don't have any tests that are predictive, at least for now. I can say that based on several studies, including ours, we should clearly anticoagulate some patients. Keep in mind that some patients develop clotting despite anticoagulation. So this is something that we should think about in everybody. Which are the risks? We go back to, though there were not direct correlation in the studies, but the studies from Italy showed that patients that were anticoagulated had lesser events, and the same thing was for us. We showed that over the years it decreases because we started to anticoagulate a quarter of the patients, clearly not enough, but we have to balance with the risk of bleeding. What to use? We're using Lovenox, so that's the heparin sub-Q, because the oral anticoagulants, potentially, they are recommended now for a lot of prevention in other diseases, but in my experience, there are no studies in Cushing's, and they are very, very hard to reverse. So imagine for patients that are going to surgery or have complications, sometimes with bleeding overall or diverticulitis, or the patients with Cushing's are very sick. So I'd be reluctant to use something that's longer term than Lovenox. I think for this, it's pretty clear that we should anticoagulate more before surgery in patients that have severe Cushing's. Now, what we don't really know, and us and others have shown the same thing, that the events are so longer after, is how long to continue. So it's safe. You ask the patients to move around. If they have bilateral adrenectomy, I continue it for 6 weeks. Should we continue up to 8? Should we? The events were up to 3 months. I didn't do that because it's not a lot of data. How much would be but the risk of bleeding is decreasing, and then also depends on, as somebody mentioned earlier, if the patients are still on supraphysiologic glucocorticoids, then definitely I will continue if we're able to taper them now nicely. But that goes back to how bad was their Cushing's before and how dependent on steroids. I would definitely stop it. That's why we said between 4 and 6 weeks.
Thank you. There is, I think, one more question. Any data on D-dimer titer post-op after wound healing? Will that value above 500 IU per ml indicate high risk of coagulation? Cutoff for discontinuation of anticoagulants?
So there is no clear data. It was one study that looked at the dimer in Cushing's, and all the other studies show that it doesn't have significance. So I don't think we have any markers right now, not PT, not von Willebrand. Though we know they are shown to be abnormal, but we don't have any cutoffs to say if this is less than, discontinue the anticoagulant, or if the PT is prolonged, you have to do that, or no, not yet. Hopefully in 10 years.
Thank you. I know there will be many more questions, but in the interest of time, we are already short the time. I would like to close the session. Before that, like to say something?
Okay. Yeah, over to the organizers for the final.
Thank you, sir.
Thank you,
Professor Maria and chairperson. Now for the final vote of thanks, I would like to invite Dr. Saptarishi Bhattacharya. Dr. Saptarishi, sir, please. Thank you.
Thank you. So we had a very, very exciting and scintillating session on pituitary over the last 2 days. I think audience who had joined from all over India and also many surrounding countries, they were extremely benefited by the wonderful lectures which all the faculties delivered. So Endocrine Society of India will like to express its sincere thanks to all the faculty members, the speakers, Professor Paramjit Singh, Professor Murta, Professor Lowe, Professor Melmed, Professor Muller, Professor Amar Ali Agha, and Professor Maria for their excellent talks. We also would like to congratulate the 2 students, Dr. Bhanu and Dr. Jasmeet, who presented 2 excellent cases. And we also would like to thank all the chairpersons who have taken out time on these 2 evenings to share their experiences and enlighten us even further. The Endocrine Society of India is grateful to the Postgraduate Institute of PGI Chandigarh, the endocrinology department, and Dr. Pinaki has been the brain behind this international pituitary conclave. So he had planned all the scientific proceedings. My sincere thanks to Dr. Pinaki for planning such a wonderful program and helping us learning more about pituitary. Dr. Lisa has the real workforce behind all these 2 days. She has been working sincerely for over the last 1 to 2 months to make this program a success. I would like to express my sincere thanks to Dr. Lisa. Also, the other organizing committee members, I would also like to extend my sincere thanks to all of them they are also very, very supportive in planning this program. I would also like to thank our web partner ExpoCon for organizing this event in a smooth way. And finally, Dr. Ganpati Bantwal, who had actually planned this program on the first place. So my sincere thanks to the President of Endocrine Society of India, Dr. Ganpati Bantwal, for planning such an excellent program. And we are looking forward many such more programs in the coming months. Lastly, my very sincere thanks to the delegates who have joined and shared their thoughts, their questions, and the success of the program is judged how much interactive it has been. We are very thankful that because of questions and your queries, the question answer sessions were really excellent, and it came out as a nice interactive learning event for all of us. I would like to say a very good night to all of you. Please stay safe, stay careful, and we are looking forward to meet you over virtual platform, and maybe sometimes again in actually physically. Thank you once again for joining. Thank you. Jai Hind.
Thank you, Professor
Thank
Maria.
you. Good night, Maria. Okay, good morning there, maybe. Okay, bye-bye.
Yeah. Thank you. Good morning. Bye. And good night. It was a pleasure to be alive.
Thanks. Thank you. Bye-bye.
Thank you, everyone. Thank you. Thank you.